हेलो दोस्तों, व्हाट्सअप। तो आज है हमारा 28 नवंबर। तो लेट्स गेट स्टार्टेड। ठीक है, पढ़ाई शुरू कर देते हैं। आ जाओ फटाफट। जो भी रेगुलर आते हैं यहाँ पे पढ़ाई वढ़ाई करने, आप आ सकते हो। ठीक है, आगे। A 5-year-old child undergoes acoustic reflex. 5 साल का बच्चा undergoes acoustic reflex testing during an evaluation of the suspected hearing loss. The result indicates the absence of stapedial reflexes at elevated sound levels. Which of the following is most likely interpretation of this finding? Normal hearing with no middle ear pathology. Conductive hearing loss. Lesion in the auditory cortex. Mild sensory neural hearing loss. कंडक्टिव का ना, क्योंकि स्टेपिडियल the absence of stapedial reflexes at elevated sound level suggests possible conductive hearing loss. क्योंकि अगर कंडक्टिव हेयरिंग लॉस होगा तभी तो ना लाउड साउंड अंदर नहीं जा पा रहा है ना। कहाँ पे नहीं जा पा रहा है? अंटिल द इनर ईयर. So while severe sensory neural hearing loss can also result in absent reflexes, elevated threshold typically point to conductive issues. Normal hearing would not show any reflex. The normal hearing would not show any absent reflexes, and mild sensory neural hearing loss is less likely to affect the reflex at elevated levels. So stapedial reflex is nothing but जब अगर कोई लाउड साउंड आ रहा है मेरे ईयर में, तो स्टेपीज का जो मसल है स्टेपिडियस दैट विल बी कॉन्ट्रैक्टेड, ओके, इन ऑर्डर टू रिड्यूस द incoming loud sound that can damage the inner ear or whatever. So muscles involved, the reflex involves the contraction of the stapedius muscle which is attached to the stapes of the middle ear. Auditory pathway. Upon detecting a loud sound, the auditory nerve sends signals to the brainstem, specifically to the cochlear nucleus and supraolivary nucleus. हाँ, तो क्या हमको याद है कल हमने जो पढ़ा था, क्या हमने पढ़ा था? The auditory pathway. Auditory pathway started from where? It started from the cochlear nerve. Okay, cochlear nerve से जाता है cochlear nuclei, where it is in the medulla. cochlear nucleus से जा रहा है, उनमें कुछ फाइबर्स है जो कि ऊपर जा रहा है, ऊपर जाने के लिए it is going into the superior olivatory nucleus. superior olivatory nucleus कहाँ गया था? डेरा. सो मेडुला में यहाँ पे कॉक्लियर न्यूक्लियस, यहाँ से जा रहा था मेरा सुपीरियर ऑलिवेटर न्यूक्लियस, सुपीरियर ऑलिवेटर न्यूक्लियस से मेरा जा रहा था न्यूक्लियस ऑफ द लैटरल लैमिनस, न्यूक्लियस ऑफ द लैटरल लैमिनस, पॉन्स में, जो कि दोनों के दोनों पॉन्स में थे. सुपीरियर ऑलिवेटर न्यूक्लियस, न्यूक्लियस ऑफ द लैटरल लैमिनस प्लस, उसके ऊपर जा रहा है इंफीरियर कॉलिकुलाई, फिर मीडियल जेनिकुलेट बॉडी, प्राइमरी ऑडिटरी कॉर्टेक्स. inferior clavicular and medial genicular body. How do I remember this? MLI, so yes, CS, limb. C is cochlear nuclei, S is superior olivary nucleus, L is nucleus of the lateral lemniscus, I is inferior claviculus, M is medial genicular body, and then primary. So C S L I M, C S L I M, C S L I M. So what are the waves? How do we remember? The waves can be remembered as E coli. Yeah, so okay. Wave 1 is distal part of the cranial nerve, that is a vestibulocochlear nerve. है ना? So distal part of the cochlear nerve has the 8th nerve, proximal part of the 8th nerve near the brainstem. So one is distal part of the 8th nerve, one is proximal part of the 8th nerve, that is wave 1 and wave 2. Wave 3 is cochlear nucleus, superior olivary nucleus. Cochlear nucleus, superior olivary nucleus. Cochlear is 3rd, superior olivary is 4th, lateral lemniscus is 5. Inferior collicula is 6th and 7th. ठीक है, क्विक रिवीजन हो गया. What is this? So here the external ear से sound जा रहा है, मिडिल से जा रहा है कॉक्लियर से जा रहा है ऑडिटरी नर्व टू कॉक्लियर न्यूक्लियस. यहाँ से सुपीरियर ऑलिवरी कॉम्प्लेक्स. ओह, सुपीरियर ऑलिवरी कॉम्प्लेक्स से एक तो सुपीरियर ऑलिवरी कॉम्प्लेक्स जा रहा है फेशियल नर्व, और क्या कॉक्लियर न्यूक्लियस जा रहा है फेशियल नर्व. तो दोनों के दोनों फेशियल नर्व जा रहा है, और फेशियल नर्व से जा रहा है स्टेपिडियस मसल. So this is ipsilateral side uncrossed reflex pathway. So this is happening ipsilateral. Okay. Contralateral pathway में क्या हो रहा है? कॉक्लियर न्यूक्लियस से जा रहा है उस साइड के सुपीरियर ऑलिवरी कॉम्प्लेक्स में, फिर वहाँ से फेशियल नर्व एंड देन वहाँ से स्टेपिडियल मसल. So if there is any loud sound from any one side, there is contraction of the stapedius muscles on the both sides. Alright. So external ear, middle cochlea, auditory nerve, cochlear nucleus, superior olivary complex, facial nerve, stapedius muscle. Again, contralateral superior olivary complex, facial nerve, stapedius muscle. Cool. Stapedial reflex. वही था ना स्टेपिडियल reflex.
Hello everyone. This question is about a 5-year-old child who was evaluated for a suspected hearing loss with a stapedial reflex test. The test inference was that the patient had an absent stapedial reflex even at elevated sound level. So which of the following is the most likely interpretation of this finding? So if we know acoustic reflex or stapedial reflex, this test basically involves giving a loud sound to the patient, and this sound travels via the external ear, middle ear and inner ear. From there the sound travels via the 8th nerve to the cochlear nucleus, from there to the superior olivary complex. From there we have lateral decussation of fibers going to the facial nerve nucleus, and from there to the facial nerve of both ipsilateral and contralateral sides. From there we have the branch which is the nerve to stapedius, which causes the contraction of the stapedius muscle. So this is the reflex arm that we see in an acoustic reflex, and if it is absent, it could be either due to a conductive pathology in the middle ear, it could be because of a cochlear pathology, it could be because of an 8th nerve pathology, it could be because of facial nerve pathology, any of these. So let's go one by one to the options to identify what is the interpretation in this clinical scenario. Option A, normal hearing with no middle ear pathology, is absolutely wrong because normally stepedial reflex is present. Option B, conductive hearing loss could be an option, so we will keep that as our answer and as a standby for the moment. Option C, mild sensory neural hearing loss, will also have stepedial reflex present. The severe sensory neural hearing loss or profound loss, where there is more than 90 decibel of hearing loss, that's when you can have an actual stepedial reflex. So mild, you will still have the reflex present. And lesion in the auditory cortex, again, will have the stepedial reflex present. So the correct answer will be option B.
A 55-year-old patient with a history of chronic otitis media, ठीक है, present with progressive hearing loss, impedance audiometry is performed. Which of the following findings would be pointing towards an underlying middle ear pathology? Type A tympanogram. Type B tympanogram, a decreased physical volume of the external auditory canal, the presence of robust acoustic reflex at normal sound intensity. Type A tympanogram, type B tympanogram. Oh, I don't even know what the fuck they asked me. So, 55-year-old patient with a history of chronic otitis media. So there is chronic otitis media. Middle ear में कुछ तो pathology है. This is chronic otitis media. ठीक है. With progressive hearing loss. Okay. Impedance audiometry. Now when I say about impedance audiometry, what do I mean? एक तो when I studied physiology, there is something called as impedance matching. जहाँ पे क्या होता है, जो मेरा sound है, air का sound है, that is getting transmitted or magnified. Where it is magnified in the middle ear. How? By the three ossicles. जो तीन छोटे छोटे bones है, उस ossicle से magnify होके फिर then it is going into the cochlea. So that is impedance matching. Now, तो यहाँ पे impedance audiometry किया जाता है. क्यों किया जाता है? To know whether that impedance matching is happening or not, right? Because the following findings will be pointing towards the underlying middle ear pathology. यहाँ पे that thing to okay, somehow I am able to understand कि what is impedance audiometry. Something they are measuring with the impedance matching का that thing. I guess I have to see. अभी I have no clue about the option. Like what is type A tympanogram, what is type B tympanogram, what is the decreased physical volume of the external ear, what is the presence of the robust, what are they asking, what are they trying to ask us? Let me put it this. Okay. I have no clue about the question and its concepts. So I need you to teach me out of it in crystal clear manner. Something is cooking up. Impedance audiometry, ना? Impedance audiometry. चलो पढ़ते हैं क्या है यहाँ पे. So what is impedance audiometry? So you're dealing with tympanometry. Tympanometry ko it is the tympanic membrane ka measurements. So what in the question, what are we dealing with? In the question we are dealing with the tympanometry, we are dealing with the chronic otitis media, and we are dealing with the tympanogram ka type. Once you get these concepts, the question will feel embarrassingly easy. Oh yeah. So what the hell is tympanometry? It's a test to check how well the medullary system works. Specifically, it measures mobility, compliance of the tympanic membrane. तो ठीक है. Functions of the ossicle. All right. Medullary pressure. Ear canal volume. Okay. Whether there is fluid perforation or blocked eustachian tube. So everything it has to do with the medulla. राइट फ्रॉम द टिम्पैनिक मेम्ब्रेन से लेके ऑसिकल्स, फिर मिडिलर का जो भी प्रेशर है, उसका जो वॉल्यूम है, इवन द यूस्टेशन ट्यूब का क्या हाल चाल है, कोई परफोरेशन है, फ्लूइड है, क्या है, so all this thing. So it doesn't test hearing, it tests the mechanical functions of the middle ear. Now machine output is a curve called tympanogram. ठीक है, तो ये सब जो है एक ग्राफ के जैसा आएगा, so that is called as tympanogram. Now the types of tympanogram and their meaning. So we have A, AS, AD, BC. ठीक है, तो A, BC के अंदर ही है, लेकिन A is divided into further two types. Now, I mean overall three types. A, AS, AD. What is A? Normal peak around 0. What is this? I need to see. Oh, that is the unit of pressure, huh? Oh. So at A, at A we have the normal peak around 0 decipascals. One normal, okay, normal. Compliance is normal. तो अगर मुझे ए ग्राफ दिख रहा है तो सब नॉर्मल है, हेल्दी मिडिल ईयर. अगर मुझे ए जस्ट दिख रहा है तो स्मॉल शैलो पीक नॉर्मल, रेड्यूस. मिडियल प्रेशर नॉर्मल है, कॉम्प्लायंस थोड़ा सा कम हो गया है. सिग्निफिकेंस क्या है, या तो ऑटोस्क्लेरोसिस है या फिर टिम्पैनोस्क्लेरोसिस है. ठीक है, ऑटोस्क्लेरोसिस नथिंग बट जो फुट प्लेट ऑफ द स्टेपिस होता है वो वहाँ पे कैल्सिफाई हो जाता है, तो वहाँ पे हार्ड हो जाता है. एंड टिम्पैनोस्क्लेरोसिस से टिम्पैनिक मेम्ब्रेन को स्क्लेरोसिस हो जाता है, हार्ड हो जाता है. सो दैट इज ए स्मॉल शैलो पीक. व्हाट इज एडी? टॉल एग्जैगरेटेड पीक्स. मिडिल प्रेशर नॉर्मल है ना, कॉम्प्लायंस है हाइपर मोबाइल. Ossicular discontinuity floppy. Ossicular discontinuity या फिर floppy tympanic membrane. B, flat line, no peak, not measurable, very low. Middle effusion. Tympanic membrane perforation, cholesteatoma sometimes. C, peak shifted towards negative pressure. Negative, eustachian tube dysfunction. Why type B matters in this case? The patient has chronic otitis media. ठीक है, तो chronic otitis media को वही है ना, फ्लैट लाइन आएगा, फ्लैट लाइन. ना तो टाइप ए आएगा ना तो टाइप बी आएगा. क्यों? क्योंकि यहाँ पे मिडिल ईयर एफ्यूजन है, टिम्पैनिक मेम्ब्रेन परफ्यूजन वगैरह. So chronic otitis media, progressive hearing loss. Chronic otitis media often leads to middle ear effusion, tympanic membrane thickening, scarring, sometimes perforation. Fluid behind the tympanic membrane prevents the movement. Got it. मिडिल ईयर में जनरली होना चाहिए हवा, कुछ ना लिक्विड होना चाहिए ना और कोई भी चीज़ वहाँ पे होना चाहिए. तो जनरली होना चाहिए हवा. वहाँ पे हवा होगा तभी वो टिम्पैनिक मेम्ब्रेन अच्छे से वाइब्रेट करेगा. अगर अच्छे से वाइब्रेट करेगा तो दैट मीन्स इट हैज़ अ गुड कॉम्प्लायंस. नाउ इफ देयर इज एनीथिंग इन द मिडिल ईयर बिहाइंड द टिम्पैनिक मेम्ब्रेन, जैसे कि इफ देयर इज एनी फ्लूइड, एनी कोलेस्टियोटोमा, एनी एफ्यूजन या फिर परफोरेशन, ऐसा कुछ भी हो जाए, तो वन थिंग, अगर कोई भी चीज़ है तो दैट विल रेंडर द टिम्पैनिक मेम्ब्रेन नॉट कॉम्प्लायंट और नॉट मूवेबल, ठीक है, नॉट फ्लेक्सिबल. That is one thing. Second thing is if there is any perforation in the what is that tympanic membrane, अगर कोई perforation हो गया, मतलब छेद अगर हो गया, कोई होल, तो बाहर का जो प्रेशर है और अंदर का जो प्रेशर है इट विल बी सिमिलर, सेम प्रेशर। अगर सेम प्रेशर होगा या कोई भी साउंड वगैरह जाएगा, आई डोंट थिंक देयर विल बी एनी गुड मूवमेंट ऑफ द टिम्पैनिक मूवमेंट। तो जिसकी वजह से भी अगेन द curve, the this thing, what is the shape of the tympanogram will be flat line, which is the B1. ठीक है, so flat curve is B type, indicates medullary pathology. Now ear canal volume helps in interpretation. Sometimes type B isn't enough, so ear canal volume clues you. So अगर नॉर्मल ईयर कैनल वॉल्यूम है तो मिडिल ईयर एफ्यूजन, अगर हाई ईयर कैनल वॉल्यूम है तो टिम्पैनिक मूवमेंट परफोरेशन और प्रेशर इक्वलाइजेस ट्यूब। लो ईयर कैनल वॉल्यूम है तो प्रो ब्लॉक। क्या? I did not understand this. Ear canal volume helps in interpretation. Sometimes type B isn't enough. So ear canal volume. अगर normal ear canal volume है, ear canal, what does it mean by ear canal? What is ear canal here? Is it the external auditory canal or is it something inside? Okay. What is ear canal? External So when tympanometry shows ear canal volume, it is measuring only the air volume in the external auditory canal. From probe tip, the tympanic movement, not the middle, because the tympanometer senses sound and measures how much comes back. If the tympanic movement is intact, the sound rests off there, so the machine only measures external auditory canal volume. But if the tympanic movement is perforated, then the sound travels through the perforation into the middle space, so the tympanometric as the middle space with external ear space, giving the higher volume reading. अच्छा, so volume interpretation becomes the diagnostic tool. अच्छा, okay. समझ में आ गया एकदम। रुको, where is it? तो अगर नॉर्मल एक्स्ट्रा कैनाल वॉल्यूम है तो मिडिल ईयर एफ्यूजन, हायर अगर है तो टिम्पैनिक मूवमेंट परफोरेशन। मतलब देखो व्हाट इज हैपनिंग हियर इज फ्रॉम द प्रोब, अगर मैंने यहाँ पे प्रोब डाला है तो उस पॉइंट से लेके मेरे मिडिल ईयर जो टिम्पैनिक मेम्ब्रेन है वहाँ तक जो भी वॉल्यूम है दैट इज़ द ईयर कैनल वॉल्यूम हियर। बिकॉज फ्रॉम देयर उस प्रोब से साउंड जब ट्रांसमिट किया जाएगा तो दैट विल बी गोइंग एंड हिटिंग द टिम्पैनिक मेम्ब्रेन एंड देन इट इज कमिंग बैक टू द प्रोब एंड ऑल। So that's how they calculate the ear canal volume. तो अगर यहाँ पे अगर वो जो tympanic membrane है अगर that is intact, so that will be normal ear volume, normal ear canal volume. लेकिन अगर वो perforate हो जाता है, अगर जो membrane है that is perforating, तो उसके पीछे क्या है मेरा, उसके पीछे मेरा middle ear cavity। यहाँ से इस probe से लेके यहाँ tympanic membrane तक जो भी ear canal volume है, plus because there is perforation here, the sound or that thing will transmit from the hole until the middle ear cavity, वहाँ तक पहुँच जाएगा ना। So this ear canal volume will be added with this volume, the middle ear volume. So in the case of perforation, tympanic membrane perforation, there will be high ear canal volume, the reading will be more. ठीक है, तो लो कब हो सकता है? प्रो ब्लॉक। हाँ, अगर यहाँ पे बीच में कोई यहाँ पे अगर वैक्स मटेरियल है, कुछ भी चीज़ है जो कि टिम्पैनिक मेम्ब्रेन से पहले ही थोड़ा बहुत स्पेस ले रही है, सो इन दैट केस देयर विल बी लो ईयर कैनल वॉल्यूम। ओके, गॉट इट। सो नॉर्मली मिडिल ईयर फ्यूजन हो सकता है, हाई हो सकता है तुम्हारा अगर कोई परफोरेशन है, ईयर कैनल वॉल्यूम परफोरेशन, एंड लो हो सकता है अगर कोई वैक्स वगैरह है तो। ओके, कूल, Now, what is acoustic reflex? Acoustic reflex causes tapetal muscle contraction in response to loud sound. Absent reflex is medullary pathology. Fluid crosses the movement. Okay. Suggest normal medullary function, so option D is wrong. Which finding points to the underlying medullary pathology? Type A tympanogram is normal. It is no. Okay. Type B tympanogram is flat curve, medullary problem, fluid S. Decreased canal volume. Not necessarily. Medullary pathology can be wax. Acoustic reflex present, suggests to healthy ear. Okay. So answer is type B. ठीक, अभी चलते हैं क्वेश्चन की तरफ। समझते हैं क्वेश्चन में क्या दिया हुआ था, हमने कहाँ पे क्या कंफ्यूजन, मतलब कंफ्यूजन तो क्या ही बोलो, दिस वाज नॉट इनसाइड माय नॉलेज बेस, सो समथिंग न्यू। नाउ आई अंडरस्टूड कि ठीक है, दिस इज द थिंग्स। तो मैंने क्या करा था, एन आंसर क्या है, तो क्वेश्चन में पूछा गया था कि एक 55-year-old पेशेंट है विथ हिस्ट्री ऑफ क्रॉनिक ओटाइटिस मीडिया, मतलब मिडिल ईयर में कुछ तो चल रहा है, कुछ तो पैथोलॉजी है, सम क्रॉनिक है, ओटाइट इन्फ्लेमेटरी समथिंग, विथ प्रोग्रेसिव हियरिंग लॉस, एंड देयर इज द प्रोग्रेसिव हियरिंग लॉस। प्रोग्रेसिव हियरिंग लॉस, हाँ, बहुत सारी चीज़ों की वजह से हो सकता है, इसकी वजह से भी हो सकता है। इम्पीडियंस ऑडियोमेट्री इज परफॉर्म, मुझे द फॉलोइंग फाइंडिंग्स विल बी पॉइंटेड टुवर्ड्स एन अंडरलाइंग मिडिल ईयर पैथोलॉजी। तो हमने इम्पीडेंस ऑडियोमेट्री करने के बाद ऐसा क्या चीज़ है जो हमको दिखाएगा कि मिडिलर पैथोलॉजी है। तो अभी तो ऑब्वियसली क्लियर हो गया, टाइप ए टिम्पैनोग्राम इज नॉर्मल, ए डिक्रीज्ड फिजिकल वॉल्यूम ऑफ द एक्सटर्नल ऑडिटरी कैनाल। अगर एक्सटर्नल ऑडिटरी कैनाल को, दैट मीन्स दैट इज नथिंग बट एक्सटर्नल ईयर कैनाल, जो भी हमने पढ़ा था, ईयर कैनाल वॉल्यूम, अगर ईयर कैनाल वॉल्यूम डिक्रीज हो गया है, तो इट डजेंट मीन कि मिडिल ईयर में कोई पैथोलॉजी है ना, क्योंकि उससे पहले क्या है, टिम्पैनिक मूवमेंट से पहले अगर कोई ईयर वैक्स है, कुछ ब्लॉकेज है, so there will be obviously reduction in the ear canal volume. So that is talking about the external auditory canal, not the internal or the middle ear. Okay, that is not concerned with the middle ear pathology. The presence of a robust acoustic reflex at normal sound intensities. तो अगर acoustic reflex है, that means stapedial reflex is working. If it is working, then the middle ear is normal. So three of them suggest that it is not a middle ear pathology. So what does it that suggests middle ear pathology? It is can be type B tympanogram, जहाँ पे या तो there is your middle ear effusion, या फिर tympanic membrane perforation, या फिर sclerosis वगैरह, ये सब हो सकता है, ठीक है, जहाँ पे जो कर्व है that is the flat line, that is the type B tympanogram. Alright, now let's hear what ma'am says.
Hello everyone, this question is asking to you about 55-year-old patient who has CSOM and progressive hearing loss. Impedance audiometry was performed and they're asking you which of the following findings would be pointing towards middle ear pathology. So if we say option A, type A tympanogram is absolutely wrong because type A is normal, and here we're talking about the pathology in the middle ear, which is why that cannot be your right answer. Option B, type B tympanogram definitely indicates to your pathology in the middle ear, where there could be fluid, there could be effusion, there could be pus, there could be perforation, there could be thickened tympanic membrane. Any of this would give you a type B tympanogram, and this could potentially be seen in a patient with CSO. So we can keep this as our answer, but let's hold it for the moment. Let's go to option C. A decreased physical volume of the external auditory canal is again wrong, because whenever we measure the volume of the canal, if it is increased, it indicates to you a perforation in the tympanic membrane, which could be secondary to CSOM. So we would expect an increased volume rather than a decreased volume, which is why option C is wrong. And the presence of acoustic reflex at normal sound intensities does not give you any inference in terms of middle ear pathology. If you have a good acoustic reflex, it tells you the middle ear, inner ear, and the eighth nerve, superior olivary complex, facial nerve, all of them are functioning well, and it has nothing to do with your middle ear pathology. So the correct answer is type B tympanogram. Thank you.
Thank you. Okay. So these are the curves, huh? Type A is normal, type A S, type A D. We have the C and the B. B is the flat line. Type A, type AD, type A, yes, autosclerosis and tympanoschlerosis. Middle ear effusion, membrane, perforation. STI junction dysfunction. So when do what does it mean when I say effusion? Effusion means जहाँ थोड़ा confusion हो रहा है तो मैं just clear कर लेता हूँ. Fusion means an instance of giving of something such as a liquid or gas. So what is a diffusion? Diffusion is a movement of the gas molecule from an area of the high concentration to the low concentration. What is effusion? Diffusion of gas through a small hole. Okay, so effusion is just a fancy medical word for fluid collecting where it shouldn't be. So when you say middle ear effusion, it means there is a fluid trapped behind the tympanic membrane in the middle ear space instead of air. ठीक है, but air की जगह कुछ तो है. So that is effusion basically. ठीक है, yeah, got it. कितने टाइप के effusion हो सकते हैं? Serous, mucoid and purulent. What do you mean by serous? Serous means thin, watery, clear, mildly yellow fluid. ठीक है. Mucoid is thick, sticky, viscous. Purulent is pus filled. Ooh. ये तो हो गया, ये हो गया. इसको मैं ले लेता हूँ ताकि फिर अगर रिवीजन वगैरह करना पड़े. Impedance, audiometry. क्या हो गया? लोड नहीं हो रहा है. अरे बोलते हैं आप. चल तो रहा है इंटरनेट, यहाँ पर क्या प्रॉब्लम है? What's happening? Internet isn't working. Subnautica. This is another game, right? Hmm. This is my friend Anisha. क्या होगा? A 48-year-old woman presents with progressive left ear hearing loss. ठीक है, एग्जाम पे दिया है. Audiometry reveals a characteristic dip in the bone conduction curve. Bone conduction more pronounced at 2000 Hz. The following okay. Cohorts notch. See, the thing is, I don't know about anything, but this thing I know. It's something with the 2000 Hz. अगर नीचे dip होता है तो that is called as cohorts notch. Cohorts. तो देखने दो क्या हो रहा है यहाँ पे. So this is my bone conduction, हाँ. तो ये जो ब्रैकेट दिया गया है, is it the what is it? Bone conduction. तो यहाँ पे मैंने 2000 हर्ट्ज, यहाँ पे सडनली ड्रॉप हो चुका है. तो दिस इज कॉल्ड इसका हर्ट्ज नॉट. दैट्स ऑल आई नो. इसके आजू बाजू मुझे कुछ नहीं पता, अभी पढ़ना पड़ेगा. कॉहर्ट्स नॉच क्या होता है, क्यों होता है, किस लिए होता है, कब होता है, क्या होता है, सब देखना पड़ेगा. मतलब पूरा का पूरा ऑडियोमेट्री अभी पढ़ना पड़ेगा. What the heck? ऑडियोमेट्री भाई, ऑडियोमेट्री टेस्ट. ऑडियोमेट्री टेस्ट कॉहर्ट्स नॉच. कॉहर्ट्स नॉच एंड अकोस्टिक डिप. ठीक है, देखते हैं इन भाई साहब.
India's first.
बैकग्राउंड म्यूजिक इज ऑन गोइंग ना, इसको निकाल दो. माइक इज ऑन गोइंग. ओके.
Startup focused business school. Our campus is built within WeWork, where we're surrounded by at least.
Hi guys, in this video we talk about Carhart's notch and acoustic dip. Carhart's notch seen at autosclerosis. It is seen at typically in bone conduction curve at 2000 Hz. Carhart's notch at 2000 Hz at bone conduction. Mind it, it is only in bone conduction. Seen in autosclerosis. This is Carhart's notch. This is 2000 Hz and there is a dip in bone conduction. This is bone conduction. Okay. But acoustic dip, it is seen at 4000 Hz at both AC and BC, both bone conduction curve and air conduction curve.
ठीक है, पर क्यों?
4000 Hz both BC and AC. It is seen in noise induced hearing loss. So Carhart's notch and acoustic dip. Carhart's notch seen in autosclerosis at 2000 Hz only in BC, but acoustic dip seen at 4000 Hz both in AC and BC. It is seen in noise induced hearing loss.
वो तो ठीक
Okay,
है.
so we can quickly
But क्यों?
revise it. Carhart's notch at 2000 Hz at BC का.
अरे भाई, सेम चीज इज रिपीटिंग. Geometry audiogram. डॉक्टर जगदीश चतुर्वेदी, हाँ तुम्हाला अच्छी.
Guys, pure tone audiometry, one of the most important concepts for your exams, vivas, and even in your practice. This is the most basic hearing test. Now, some of the important things here is that this is a subjective hearing test. Okay, so first point is it is a subjective test. What do you mean by subjective? Subjective meaning that it is a test that relies on the patient's inputs. So patient is put in a soundproof room, and the examiner or the audiologist is going to give them different levels of volume and frequency of sound. Decibel hearing level, not decibel hearing loss. Decibel hearing level, dBHL, is this 10, 20, 30, 40, 60. This is the volume. So when we're talking with low volume and going to high volume, that is volume. All right. And hertz is frequency, where we are going from low frequency to high frequency. Frequency is the pitch. Decibel is the volume. A combination of frequency and volume, we are giving sounds to the patient, and patient is asked, can you hear the sound? Patient says yes. He says, when you stop hearing the sound, you let us know. Because the examiner is mapping threshold. It is called threshold. Threshold matlab, what is the minimum one can hear? Pure tone audiometry is a threshold test, which means we are not examining the patient's highest sounds that they can hear. We are examining what is the least that they can hear. मतलब whatever line we draw over here, if we put any sound above that, they cannot hear. उसका मतलब ये है. We are testing what is the least they can hear. So if anybody is able to hear in this range from 0 to 30 decibels, generally anybody hearing in this range, that is considered normal. Okay, anything that is in the 20 to 30 decibel range, if you're getting the graph falling there, that is normal. All right. Now, if the hearing is more in the volume or the hearing is more in the frequency, that will tell us different types of hearing losses. Okay. Now, the most complex thing, see, everything can be taught by concepts, but one of the things that students struggle the most with is the symbols. The symbols that we are going to use for this. For that, you have to understand that we will do two types of testings. Okay, so we do what is called as an air conduction testing, and we do what is called as a bone conduction testing. Air conduction testing also, it will be one without masking, and there will be with masking. Similarly, bone conduction will be without masking, and then there will be with masking. Okay, so what is this? Air conduction is an air conduction pathway. Similarly, like when you strike a tuning fork and you place outside, you are checking the air conduction pathway. Air conduction pathway is this. So suppose this is an ear canal, eardrum, 3 ossicles. That is the air conduction pathway. Whereas the bone conduction pathway is the cochlea and the hearing system. This is the bone conduction pathway. If we trigger this directly, so air conduction pathway, the sound is going like this. But in bone conduction pathway, we are directly triggering the skull and thereby triggering the cochlea. That is the bone conduction pathway. So we are testing the air conduction pathway and the bone conduction pathway. So the patient is given a headphone. And headphone ke piche hota hai, there is this place where a probe is also touching the mastoid bone. Now when the sound is coming directly into the headphone, we are testing the air conduction. That time kya hota hai, the examiner opposite side will start giving some shwee, 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 shwee. So this side is masked. When that is happening, masking is done on the opposite side. Then you are purely just testing that one side of the ear. That is called air conduction with masking of the opposite side. If you don't mask, then here the sound is coming, but here also other sounds person can hear. So sometimes it may interfere with their hearing. So obviously when you mask one side, this side you can exclusively tell ki kitna unka hearing threshold hai. Similarly, bone conduction, you are giving the vibration in the mastoid, and if you mask the other side by giving chwine, 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 then you are only testing bone conduction with masking. If there is no masking, then it's called without masking. So with this, we basically test the entire hearing system, and you have to now understand the logic behind the symbols. You might think that there is no logic behind the symbols. I've seen many students struggling with ये जो symbols हैं pure tone audiometry के बहुत confusing है. What is the logic? I spoke to one of the most senior audiologists in our country who has written many books, Dr. Reban Biswas, and he was the one who was able to tell me how these symbols originated, and I'm going to tell it to you. It will become very easy for you. All right. So first, remember that we have the symboling which is very much related to the alphabet. So alphabet से symbols आते हैं. So there is a right side and then there is a left side. Okay, so there is a right side and the left side. So let's make this blue and let's make this red. Okay, so there is a right side which is red and left side which is blue. Okay, now how this red came? Because here red ka R is red and blue ka L. Okay, so that is how the symbol of R and L being blue has come. Because red has R and blue has L, they thought right and left, this would be a logical way to give the symboling. Now you see all the symbols will originate from these letters. Now suppose if I were to draw this R little bit differently, like suppose if I were to draw the R like this, right? This is also like an R, but you can see that iske upar wala part becomes a 0 and lower one part can become a triangle. So that is how the symboling has come for. So air conduction, O means no. No means no masking. Air conduction without masking. Whereas this is air conduction with masking. The one which is not saying O. O means no without masking, right? And this triangle means close, so it is masking. So that is how from the R, this 0 and the triangle are derived to say without masking, with masking. So L में कैसे करते हैं? These are two straight lines, right? So the two straight lines are rearranged into an X. That is air conduction without masking. X means no masking. And you rearrange these four into a square. That is air conduction with masking. So you see how these symbols have basically originated from the letters. The letters have originated from the colors. So show which is right and which is left. Now, bone conduction. Bone conduction is a little bit more easy. Okay, so we have bone conduction without masking. And we have bone conduction with masking. In bone conduction, they basically found out that the whichever side is the bracket opening, that side is the one we are testing. So for example, without masking, they use this symbol. This is opening towards the right side, not pointing to the right side, which is the open side. Like this is the open side. So this is the masking of the right side, bone conduction without masking. Similarly, this is pointing towards the left side, right? So the left side, it is not pointing, the opening side is left side. So this is bone conduction on the left side. And with masking, they use this symbol. Now I remember it as almost like M, right? If you make this like this, looks like an M with masking. So this is how the masking is, symbols are, but you have to see which side it is which is the open end towards. So the right side, this side, so this is open on the right side. So this is right side masking and without masking symbols. And this is opening towards this side, left side with masking, without masking symbols. Okay. Now there are some more symbols. These are the common ones. Here it is implied that whatever you are doing bone conduction, this is on the mastoid. Okay, this is mastoid. There are other parts also you can do. You can do forehead. So bone conduction you can do on forehead with masking. With masking. So if you do bone conduction of forehead with masking, here the symbols are little different. It is like this and it is like this. Now, how do you remember this? See, your forehead, you have two prominences. You have the right side prominence and you have the left side prominence. So you can place, the probe which is producing bone conduction sound on the right side of the forehead. You will say, why use the forehead? Why not the mastoid? Sometimes people have undergone mastoidectomy. There are surgeries that are done where the mastoid bone is mostly removed, or some implants are there, or for some reason you cannot use the mastoid area. Then how do you test the bone conduction? You have to have an alternate way, and that is the forehead. And forehead has two prominences. There is a right side and the left side. Now, whichever side you are placing the vibrating frequency, that is where. So suppose if you were to draw a face, like let's say if I were to draw an imaginary face like this, the right part of the forehead, if you are testing, then that would be pointing here. Whereas this is the eyes, this is the nose, this is the face. This is the right side of the forehead. Similarly, this is the left side of the forehead. So that is how you remember it. Now, if you're not masking it on either side, Then when you're not masking anything on bone conduction, you have to place it central, like we do in Weber's test. We play it vertex. So when you are doing bone conduction of forehead without masking, you're basically just placing it in the middle. So all of these symbols have a particular derivation and you can remember it. Like R ka O means no masking, X means no masking, coming from L. Air conduction with masking, you have a triangle, this is a square. Triangle is coming from lower part of R, square is coming from rearranging the same lines. Similarly, bone conduction mastoid, right side, it is opening towards the right side. With masking, this looks like a mask and also looks like M. So this is opening towards which side? That side it is. If you're doing forehead with masking, you're pointing at which forehead you are placing the vibrating substance. And bone conduction without masking will always be central. One more thing that you have to remember. One more symbol that you have to remember, which is if the patient is not giving a response. Like I told you, this is a subjective test. What if patient को जवाब ही नहीं देना है? You know, how much of the examiner saying, can your patient is not giving the response? Then there is a particular symbol that you use for no response. On right side, if you put an arrow like this, it means no response given. And left side, if you put an arrow like this, means no response given. किसी भी symbol में if in air conduction में response नहीं दिया, then it becomes like this. Okay? Like this. If bone conduction में response नहीं दिया, then it becomes like this. So anywhere you can put this symbol would mean that the patient did not give that response. So in your MCQs, if any of these symbols are asked, this is an easy way, logical way, remembering from how it originated, because even the ones who came up with this kind of, what do you say, symboling system also came in a particular manner, so they can also remember, and it is derived largely from the alphabetical system. All right. So now this is about subjective hearing test threshold, and you have understood now how all the symbols come. So how is this plotted?
अरे
I wanted to follow my passion. Now I can use my background in engineering and my passion for HR to
अरे
support a
यार
global
निकलो
team.
ना. Where is the part 2 of the video?
Guys,
जगदीश सर, आपने पार्ट 2 नहीं बनाया क्या? एब्सोल्यूट बोन ट्यूनिंग फॉर ऑडियोमेट्री. ऑडियोमेट्री का पार्ट 2 चाहिए हमको.
guys, Weber's tuning fork test, do not remember it as
चलो कुछ तो समझ में आया. सिंबल्स के बारे में तो कुछ समझ में आ गया.
in a particular manner, so they can also remember.
Screenshot
and it is
ले लेते
derived
हैं,
largely
screenshot.
from the alphabetical system. All right. So now,
We'll take this screenshot. क्वेश्चन में वापस चलते हैं. अगर यक्स है तो ये मतलब लेफ्ट साइड में है, और अगर ब्रैकेट है दैट मीन्स दैट इज द मास्किंग वाला ना. ब्रैकेट वाला इज लाइक एम काइंड ऑफ. अगर ब्रैकेट इस तरफ से खुल रहा है तो राइट साइड, अगर इस तरफ से खुल रहा है तो लेफ्ट साइड. तो दिस इज द राइट साइड वाला, एंड एक्स वाला तो आ जाएगा लेफ्ट साइड वाला. ठीक है. तो दिस इज योर बोन कंडक्शन. ओ ब्रैकेट वाला आ जाएगा बोन कंडक्शन, एक्स वाला आ जाएगा एयर कंडक्शन. ठीक है. ठीक है ठीक है ठीक है ठीक है ठीक है. दिस इज एयर कंडक्शन, दिस इज बोन कंडक्शन. ओके. So for it progressive left here is left ear this one. तो ये वाला left ear bone conduction का more cohort notch? What is Boiler's notch? What is age related this thing? अरे आई नीड सम वीडियो लेक्चर, मुझे पेपर में देखना पड़ेगा. नाउ आईपैड इज इन यूज, सो व्हाट द फक. ये देखना है मुझे.
Hi guys, this is Dr. Kirotan Napanda back again to talk about topics related to otolaryngology and audiology. Today, I will be talking about why there is a notching the 2 kHz bone conduction threshold in otosclerosis, popularly known as Carhar's notch. Before explaining the phenomena, we need to understand what is otosclerosis. As you all know, auto means pertaining to the ear and sclerosis is dense formation of bone. It's a hereditary localized disease of bone which arises from the otic capsule, in which the natural lamellar bone is replaced by spongy bone of increased vascularity, cellularity and thickness, giving rise to conductive hearing loss with patent nasopharyngeal cavities.
What?
Now in the initial stages, it gives rise to conductive hearing loss when there is fixation of the stapes to the oval window.
ये तो पता
And in
है.
later stages, it brings out mixed hearing loss.
हम्म.
Now this otic capsule signifies bony labyrinth. Bony labyrinth has got 3 layers: endosteal, enchondral and periosteal. Endosteal is the innermost layer of the bony labyrinth. It lines the bony labyrinth. Enchondral develops from a cartilage and later ossifies into bone. Now it is in this layer that some islands of cartilage are left unossified and later gives rise to otosclerosis. And this is the main pathophysiology of otosclerosis.
देखो क्या क्या है.
Enchondral develops from the cartilage and later ossifies into bone. Now it is in this layer that some islands of cartilage are left unossified and later gives rise to otosclerosis. And this is the main pathophysiology of otosclerosis.
Left
Periosteal,
unossified.
it covers the bony labyrinth. Now there is no exact cause of otosclerosis. However, the following facts have been documented in medical science as the etiologies of otosclerosis. Age. It occurs in between the age of 20 to 30 years, but pretty rare below the age of 10 years and above the age of 40 years. Sex. Females are more affected than males, and females are twice as often affected as males. Some syndromes are associated with otosclerosis like Van der Waals syndrome, musculara, osteogenesis imperfecta, and otosclerosis. It is autosomal dominant type. You would observe 50% of the cases will have positive family history, and the affected members of the same family may have the same blood group. Otosclerosis aggravates during pregnancy, after menopause, after laser surgery, or accident.
अच्छा ये एक देख लेते लास्ट है ना.
This is your brain when you're
अच्छे से
struggling
समझ
to
लेते हैं
focus.
बिकॉज दिस इज
And
इम्पोर्टेंट.
this is your brain when you're in the zone.
एंड देन इसके बाद मुझे प्रिपलेटर में मैम का वीडियो भी देखना है.
Alright, so welcome to this video on audiograms. After this video, you should be able to describe the process of audiometry, demonstrate an understanding of how an audiogram links to tuning fork tests, diagnose normal hearing from an audiogram, diagnose conductive and sensory neural hearing loss from audiograms, and diagnose common causes of hearing loss from audiograms. Let's first quickly recap the bedside hearing assessments you will have practiced during the ENT examination, starting with Rinne's test, which compares air conduction to bone conduction. Air conduction involves sound being funneled via the pinna into the ear canal, where it passes through the tympanic membrane and ossicles. Sound is amplified here because movements of the stapes vocalate are translated into movements of fluid within the cochlea, resulting in neural stimulation. Remember, in Rinne's test, if air conduction is louder than bone conduction, this is normal and shows sound can go through the middle ear amplifier. This is a positive Rinne's test. During bone conduction, however, sound misses the ossicles and there is direct vibration of the inner ear fluids with no amplification. If bone conduction is louder, this suggests that there is a defect, either preventing the sound's route to the cochlea or its amplification. This is a negative Rinne's test. Weber's test is a little bit more confusing to interpret. Let's say one ear was positive in Rinne's test, i.e. bone conduction was greater than air conduction, shown here as a cross in the left ear. If Weber's lateralizes towards the good ear, the hearing loss is sensory neural. However, if it lateralizes towards the affected ear, the hearing loss is conductive. This being said, the nature of hearing loss is more reliably measured using the pure tone audiometry when it is available. An audiogram is a graphical representation of a person's ability to hear at different standardized frequencies. It builds on what you may have found with Rinne's and Weber's tests. Whilst you are unlikely to be creating an audiogram yourself, it is important to know how they are done in order to interpret them effectively. Firstly, the ears are cleaned of wax and discharge. Then the patient is placed in a soundproof room and pure tones over a range of frequencies are delivered to the patient through headphones at varying intervals and intensities. Each ear is tested separately. The patient presses a button when they can hear a noise. The first noise played should be the one that the patient can hear, so the patient knows what the sound is and which ear they should be hearing it in. Once the patient presses the button, the noise is reduced in frequency by 10 decibels until the patient can no longer hear it. The process is repeated, but a bone oscillator is placed over the mastoid process, which vibrates at different frequencies. This vibration will travel directly to the cochlea and stimulate it. This means that we can test the function of the cochlea separately. The frequencies and intensity at which some common noises are heard can be shown in an audiogram. Although rarely done in practice, you can plot the average levels for speech, which forms the speech banana. You do not need to learn this, but bear it in mind as it nicely demonstrates why losing hearing at certain frequencies affects how a person hears speech, and therefore how they are able to communicate. This is a blank audiogram. Frequency is along the x-axis in hertz, and the intensity is along the y-axis in decibels. Normal hearing for an adult is between 0 and 20 decibels across all frequencies. A key is provided on the right of the graph, as symbols may vary. With this patient, we'll test the right ear first.
Red is right, blue is left. Red से बनता है O and triangle. So both are for the ear conduction, no? O and triangle, and left से बनता है मेरा X and box for the ear conduction. Bone conduction के लिए right में बनता है मेरा ब्रैकेट ओपन, वो ऐसा वाला ब्रैकेट और बड़ा वाला ब्रैकेट for the bone conduction. यहाँ पे भी same.
Starting at a frequency of 1000 Hz, a noise is played that the patient can hear comfortably. The intensity is lowered in 10 decibel steps until they can no longer hear it. Once they can't hear it, the volume is adjusted up and down in 5 decibel steps until a threshold that the patient hears 50% of the time is reached. And then
There is a round, that means it is right side का ear conduction. ठीक है.
is made. Next, the patient is played a noise at 2000 Hz at 25 decibels. They can hear it, so it is reduced to 15 decibels. They can no longer hear it, so now it is increased to 20 decibels. Patient presses the button and another mark is made. The process is continued all the way to 8000 Hz and then back to 250 and 500 Hz before it is repeated at 1000 Hz. The whole thing is also repeated in the left ear. As the patient was consistently able to hear the noises below 20 decibels, they have normal air conduction in both ears. As air conduction was normal bilaterally, they have normal hearing in both ears. If you were examining this patient with a tuning fork, Rinne's would be positive bilaterally and Weber's would not lateralize. Conductive hearing loss is the name given when a sound is unable to properly reach the cochlear nerve. Regardless of whether the pathology is in the outer ear, tympanic membrane or the middle ear, the sound is unable to travel through the middle ear and is therefore not amplified as would be normal. There are many different reasons for this, such as otitis media, perforation, wax, otitis externa, otosclerosis, foreign objects, and cholesteatoma. Now let's look at how conductive hearing loss presents on an audiogram. The test is carried out as before. Whilst the right ear appears normal, This time the patient's left ear falls around the 60 decibel mark. They have hearing loss in their left ear. At the moment, we cannot tell if this is conductive or sensory. We need to know the bone conduction. In this case, the patient records the following plot points, all of which fall below 20 decibels, indicating normal bone conduction. This demonstrates that the nerve is working appropriately, but there is a defect in the ear canal, tympanic membrane or ossicles. Therefore, this patient has conductive hearing loss in their left ear, possibly as a result of otitis media, perforation, glioblastoma, or middle ear tumour. Rini's would be negative on the left.
With AI,
You can create any character you want in seconds.
this used to require
Yeah,
huge
Marty.
Hollywood budgets.
And Weber's would lateralize.
रुको ओके तो अगर मैं इस ग्राफ को देखूंगा सो देयर आर थ्री थिंग्स हियर वन इज द रेड लाइन द अदर वन इज ब्लू लाइन रेड इज ऑब्वियसली द राइट साइड ब्लू इज ऑब्वियसली द लेफ्ट साइड नाउ O in the red suggests that it is the air conduction तो it is falling below the 20 decibels जो कि नॉर्मल होता है ठीक है लेकिन यहाँ पे क्या हुआ है जो X है X मीन्स माई लेफ्ट ईयर का एयर कंडक्शन यहाँ पे डिक्रीज मतलब ये ज़्यादा इस पे उसको नॉर्मल लेवल पे सुनाई नहीं दे रहा है नॉर्मल अगर बिलो 20 है तो नॉर्मल है वो लेकिन यहाँ पे ऑलमोस्ट 60 डेसिबल पे उसको सुनाई दे रहा है थ्रू द एयर कंडक्शन तो भी एयर कंडक्शन में अगर ऐसा है तो वेदर इट इज़ ए प्रॉब्लम ऑफ दिस वन न्यूरल का प्रॉब्लम है या कंडक्शन का प्रॉब्लम है ये मुझे जानना है कि वेदर इट इज़ ए नर्व का प्रॉब्लम या फिर इनसाइड जो कॉकलिया है वो जो सेंसिंग ऑर्गन है उसका प्रॉब्लम है या फिर कंडक्शन में कोई प्रॉब्लम है दैट आई हैव टू नो तो उसके लिए आई विल आल्सो डू दी बोन कंडक्शन नाउ बोन कंडक्शन मेरा आ गया नॉर्मल क्योंकि बिलो 20 हर्ट्स में मुझे सुनाई दे रहा है ठीक है सॉरी नॉट हर्ट्स डेसिबल्स में मुझे सुनाई दे रहा है तो बोन कंडक्शन तो नॉर्मल तो बोन कंडक्शन मीन्स व्हाट इट इज डायरेक्टली एंटरिंग माई सेंस ऑर्गन ओके एंड वहाँ से मेरा ब्रेन में जा रहा है इसका मतलब मेरे सेंस ऑर्गन में तो कोई प्रॉब्लम नहीं है ना बिकॉज उस ऑर्गन से तो जा पा रहा है ना बोन कंडक्शन में सीधा वहीं पे जाएगा पासिंग बाई पासिंग द मिडिल ईयर बाई पासिंग द कंडक्टिव पाथवे so that means this graph tells me that there is some kind of conductive hearing loss that's what she is trying to say right
At the moment, we cannot tell if this is conductive or sensory. We need to know the bone conduction. In this case, the patient records the following plot points, all of which fall below 20 decibels, indicating normal bone conduction. This demonstrates that a nerve is working appropriately. There is a defect in the ear canal, tympanic membrane or ossicles. Therefore, this patient has conductive hearing loss in their left ear, possibly as a result of otitis media, perforation, glioblastoma, or middle ear tumour. Rini's would be negative on the left, and Weber's.
now what do we mean by Rini's negative Rini's positive मतलब होता है एयर कंडक्शन इज ग्रेटर देन द बोन कंडक्शन Rini's नेगेटिव मतलब बोन कंडक्शन इज ग्रेटर देन द एयर कंडक्शन व्हिच इज अब नॉर्मल क्योंकि जनरली एयर कंडक्शन ज़्यादा होना चाहिए क्यों क्योंकि जो एम्पलीफायर है दैट इज वर्किंग प्रॉपर्ली सो दैट इज Rini's पॉजिटिव बट इन दिस केस द एम्पलीफायर इज नॉट वर्किंग और सम कंडक्शन पाथवे देयर इज सम डिस्ट्रप्शन ओके
Lateralized to the left. Sensory neural hearing loss is the name given when the pathology is beyond the middle ear. Sound is able to be transmitted through to the inner ear, but due to disease, it cannot be transduced into neural activity by the cochlea and transmitted by the nerve. There are many different reasons for this, such as acoustic neuroma, Meniere's disease, ototoxicity, labyrinthitis, noise damage, head trauma, and presbyocusis. A patient produces an audiogram as before, demonstrating hearing loss in their left ear, particularly in the higher frequencies. Once again, the test is repeated for bone conduction. However, this time, bone conduction is also deficient, demonstrating that there must be a problem with the cochlea or nerve, and making this unilateral sensorineural hearing loss. In this instance, Rini's would be positive bilaterally, but Weber's would lateralize to the right. If you see an audiogram like this, you must first rule out an acoustic neuroma and organize an MRI scan. Other differentials could be surgical damage or noise trauma. Let's look at some common conditions and their audiograms, which you may be asked to interpret either on the wards, in clinics, or during exams.
रुको मुझे इंटरप्रेट करने दो। तो यहाँ पे क्या हुआ है, 250 हर्ट्स पे नॉर्मल है, दोनों के दोनों। पहले तो रेड है राइट और ब्लू है लेफ्ट, वो मतलब एयर कंडक्शन, एक्स मतलब एयर कंडक्शन, दोनों के दोनों यहाँ पे एयर कंडक्शन पे मैंने चेक करा है। तो 250 हर्ट्स पे नॉर्मल है, क्योंकि दोनों के दोनों 20 डेसिबल्स के नीचे है, सो दैट इज बोथ आर नॉर्मल। ओके, नेक्स्ट 500 हर्ट्स में भी नॉर्मल है, क्योंकि दोनों के दोनों बिलो 20 है। नाउ देर इज इंटरेस्टिंग पॉइंट हियर, यहाँ पे। तो यहाँ पे जब मैंने 1 किलो हर्ट्स दिया है फ्रीक्वेंसी, ठीक है, सो दिस इज कमिंग बिलो 20, जो कि नॉर्मल से थोड़ा कम है। यहाँ पे थोड़ा सा हियरिंग लॉस है, दोनों राइट ईयर में भी है, लेफ्ट ईयर में भी है, एंड दैट इज व्हाट, दिस इज द एयर कंडक्शन, ठीक है, क्योंकि एक्शन ओवर एयर कंडक्शन। फिर यहाँ पे 2000 हर्ट्स में और ज़्यादा कम हो गया, 4000 हर्ट्स में और ज़्यादा कम हो गया, 8K में और ज़्यादा कम हो गया। तो जैसे जैसे मैंने फ्रीक्वेंसी बढ़ाया है, वैसे वैसे मुझे मतलब लाउडनेस और बढ़ाना पड़ा है, ठीक है। यहाँ पे ये तो नॉर्मल था, फिर यहाँ पे अब नॉर्मल मतलब बहुत ज़्यादा यहाँ पे लॉस है। क्या लॉस है? हियरिंग लॉस है, क्योंकि उसको 8K हर्ट्स 70 डेसिबल्स पे सुनाई दे रहा है, ठीक है। हायर फ्रीक्वेंसीज आर लॉस्ट इन बोथ द ईयर्स। हाँ, दिस इज द इंटरप्रिटेशन।
Shows bilateral high frequency hearing loss. It is worth noting here.
अभी हम यहाँ पे करा है बोन कंडक्शन। तो बोन कंडक्शन करने के बाद क्या है, यहाँ पे है बोन कंडक्शन भी लॉस है। तो एयर कंडक्शन भी गया, बोन कंडक्शन भी गया, आई मीन या सो इसका मतलब दिस इज नॉट कंडक्टिव हियरिंग लॉस, दिस इज नॉट कंडक्टिव, दिस इज समथिंग टू डू विद द न्यूरल थिंग और द कॉक्लियर जो सेंसिंग ऑर्गन है। So bone conduction markers are often removed for clarity. Bone conduction markers are often removed for clarity and can be assumed to follow air conduction. क्या?
Follows the same pattern as air conduction. It is often not displayed on the audiogram simply to make it more legible. Therefore, this is sensory neural hearing loss and is typical of presbycusis.
हाँ वही तो, so that thing, this is not any conductive issue or anything. Conduction में कोई issue नहीं। अगर conduction में कोई issue होता तो एयर सिर्फ एयर में ही लॉस होता, एयर कंडक्शन में ही लॉस होता, लेकिन बोन कंडक्शन तो नॉर्मल ही रहता ना, क्योंकि दैट इज गोइंग डायरेक्टली टू माय इनर ईयर कॉक्लिया, और वहाँ से मेरा न्यूरल सिग्नल्स में ब्रेन तक चला जाता। बट इन दिस केस एयर कंडक्शन भी गया, बोन कंडक्शन भी चुदा। तो इन दिस केस या दैट थिंग देयर इज सेंसरी न्यूरल हियरिंग लॉस, either there is a problem in my inner ear का कॉक्लिया, द सेंसिंग ऑर्गन, और द नर्व।
A particular issue for those suffering presbycusis is listening to speech. If you refer back to the speech banana, you can see that high frequency sounds such as f, s, ch, and sh, and many consonants will be difficult to hear. As the loss is bilateral, you are not likely to see anything unusual on tuning fork testing, other than a gross hearing difficulty. This demonstrates the usefulness of an audiogram. The abnormal part of this audiogram is the dip at 4K. This has affected both ears and can be
Okay, let's interpret this one. यहाँ पे क्या है, तो पहले मेरा 2K हर्ट्ज तक मेरा नॉर्मल है, एयर कंडक्शन ऑफ बोथ द ईयर्स, राइट एंड लेफ्ट दोनों के दोनों यहाँ पे नॉर्मल है, अंटिल कितना, अंटिल 2 किलो हर्ट्ज। सडनली 4 किलो हर्ट्ज में यहाँ पे हो गया ड्रॉप, 4 किलो हर्ट्ज में सडनली ड्रॉप होके चला गया 40 डेसिबल्स तक, एंड देन फिर 8K में ऑलमोस्ट नॉर्मली सुनाई दे रहा है। तो दिस इज सम कैरेक्टरिस्टिक, इसका कुछ तो नाम होगा भाई, ठीक है, कुछ तो नाम होगा यहाँ पे इसका, जैसे यहाँ पे करहर्ट्ज में कुछ तो नाम था, इसमें भी कुछ तो होगा। सो दिस इज व्हाट इज हैपनिंग हियर। सो यहाँ तक तो नॉर्मल है, और अभी मुझे बोन कंडक्शन चाहिए। बोन कंडक्शन जानने के बाद मुझे पता चलेगा कि यहाँ पे क्या प्रॉब्लम हो रहा है। ये कंडक्टिव हियरिंग लॉस तो नहीं लग रहा, बिकॉज यहाँ पे बाकी सब तो ठीक है, सिर्फ इसी पे यहाँ पे ड्रॉप हुआ है। कंडक्टिव हियरिंग लॉस है क्या है?
Noise induced hearing loss. People who are
So this is called as noise induced hearing loss, हाँ, bilateral sensory neural loss, 4K dip, acute or chronic exposure to loud noise। अच्छा, सडनली अगर तुम लाउडनेस सो एक्सपोज हो गए, उसको एक्सपोज हो गए, तो देर विल बी दिस काइंड ऑफ डिप एट सर्टेन फ्रिक्वेंसी. और थोड़ा जानना पड़ेगा मुझे, और क्लियरिटी चाहिए मुझे, कहीं ना कहीं कुछ तो थोड़ा सा कन्फ्यूजन.
Exposed to loud noises, such as construction workers, musicians, or military personnel, for example, may present with bilateral sensorineural hearing loss. Whether the damage is acute or chronic, the loud sound overstimulates the fragile hair cells, leading to their permanent injury or death.
In everyone's life, there comes a moment when they understand the growth that they have been having till then.
Higher frequencies are more damaging to the hair cells. Therefore, noise-induced hearing loss has a typical tick appearance on audiogram around the 4000 mark. This patient has a low
इसको
frequency.
देखते हैं. तो यहाँ पे मेरा राइट साइड वाला एयर कंडक्शन इज प्रिटी मच नॉर्मल थ्रू आउट. ठीक है, राइट साइड एयर कंडक्शन. लेकिन लेफ्ट साइड में जो एयर कंडक्शन है वो धीरे धीरे इम्प्रूव हो रहा है, जैसे मैं फ्रीक्वेंसी इम्प्रूव करते जा रहा हूँ, इंक्रीज करते जा रहा हूँ. तो लो फ्रीक्वेंसी पे मेरा हियरिंग लॉस है अंटिल 1K. ठीक है, और अगर मैं बोन कंडक्शन में देखो तो वो भी कम है. बोन कंडक्शन वहाँ पे मेरा 500 और वहाँ पे मेरा 1K भी सिमिलरली आ रहा है. ठीक है, तो यहाँ पे बोन कंडक्शन और एयर कंडक्शन दोनों के दोनों 1K तक मेरा लॉस में है. तो व्हाट इज द इंटरप्रिटेशन? उसके बाद यहाँ पे नॉर्मल है. बोन कंडक्शन में गया है तो फिर से वही है ना, मतलब कंडक्टिव हियरिंग तो लॉस और हियरिंग लॉस तो नहीं है. समथिंग टू डू विथ द सेंस ऑर्गन ओनली. नो, व्हाई इज इट कि लो फ्रीक्वेंसी में ऐसा हो रहा है, हाई फ्रीक्वेंसी में ठीक सुना दे रहा है. देखना पड़ेगा. लो फ्रीक्वेंसी सेंसरी न्यूरल, तो दिस इज कॉल्ड एज लो फ्रीक्वेंसी सेंसरी न्यूरल लॉस. बस इतना ही. बट होता क्यों है?
Unilateral sensorineural hearing loss, typical of Meniere's disease.
ओह,
In Meniere's disease,
अच्छा, मीनियस में ऐसा होता है क्या?
the hearing loss fluctuates, which is highly unusual. However, the hearing loss will become permanent and
ओके,
progressive.
सो फॉर द गाइस हु डजंट नो व्हाट इज मीनियस डिसीज में क्या होता है कि जो मेरा बोनी लैब्रिंथ के अंदर क्या होता है, दो टाइप का फ्लूइड होता है. एक है मेरा पेरिलिम्फ और एक होता है मेरा एंडोलिम्फ. एंडोलिम्फ किस में होता है? जो मेम्ब्रेनस सैक होता है बोनी लैब्रिंथ के अंदर, मेम्ब्रेनस लैब्रिंथ, उसके अंदर होता है मेरा एंडोलिम्फ. और बोनी लैब्रिंथ के अंदर होता है मेरा, मतलब जो मेम्ब्रेनस लैब्रिंथ है उसके पेरिफेरी में होता है मेरा पेरिलिम्फ. तो दो टाइप का फ्लूइड होता है, एंडोलिम्फ एंड पेरिलिम्फ. नाउ इफ देयर इज बाय चांस ए लीक, जो मेरा एंडोलिम्फ है ना, अगर वो मिक्स हो गया पेरिलिम्फ से, वो मेम्ब्रेनस लैब्रिंथ बर्स्ट हो गया, ओके, सो ऑल दिस थिंग कैन कॉज मीनियस डिसीज. तो जो मेरा पेरिलिम्फ है उसके अंदर बहुत ज़्यादा सोडियम होता है, सोडियम का लेवल बहुत ज़्यादा होता है, और एंडोलिम्फ में मेरा पोटेशियम का लेवल बहुत ज़्यादा होता है. सो दिस मिक्सचर ऑफ सोडियम एंड पोटेशियम causes abnormal signal discharge and all, so that thing causes Meniere's disease. उसमें वो सिग्नल बहुत ज़्यादा सुनाई देगा ना, बेरा में सिग्नल वन या फिर ऐसा कुछ था.
Not be prevented even with treatment. In this instance, Rinne's would be positive bilaterally, and Weber's would lateralize to the right, as we use a low frequency 512 Hz tuning fork. If you see an asymmetric sensory loss like this, you must first rule out an acoustic neuroma and organize an MRI scan. In this audiogram, both ears are affected and both show bone and air conduction deficits. Therefore, this is bilateral sensorineural hearing loss. Although rare in the UK, a possible differential for bilateral sensorineural hearing
Ototoxicity.
loss is ototoxicity. It can be caused by a
Drugs.
number of drugs, such as
Amikacin,
amyloid
gentamicin,
peptides, such as
furosemide.
gentamicin, loop diuretics, or aspirin, if taken in high enough quantities. Other differential diagnoses could be trauma or bilateral acoustic neuromas if the patient suffers from neurofibromatosis 2, for example. Like before, this audiogram shows damage to both ears. However, bone conduction is preserved, indicating that
Conductive
this is a
hearing loss.
bilateral conductive hearing loss. The commonest cause of this appearance is blue ear. Bilateral perforations is a possibility, as is otosclerosis. Otosclerosis is a condition that lays down spongy bone around the stapes footplate. It is commoner in younger women and has genetic, hormonal, and viral origins. This time, there has been little to no response at all from the left ear.
यहाँ पे राइट साइड पे मेरा एयर कंडक्शन नॉर्मल है, लेफ्ट साइड में तो मेरा गया, लेफ्ट साइड पे सेंसरी न्यूरल हियरिंग लॉस पूरा का पूरा.
This is known as dead ear. The arrows demonstrate that the machine was not loud enough for the patient to register a response. Although there appears to be a response to an 80 decibel noise at 250 Hz,
Unilateral
do not
sensory
be
neural
fooled
hearing
into
loss.
thinking the ear is working. This is the vibrotactile response.
The patient feels the vibration rather than the hearing the sound.
Common causes of a dead ear would be labyrinthitis, accidental trauma to the temporal bone, and post-surgical.
Black Friday sale, huh?
If they previously had an acoustic neuroma removed, for example. In this instance, Rinne's would be positive bilaterally, but Weber's would lateralize to the right. In this example, there is
Again, sensory neural hearing loss. Some, thoda sa. Hearing loss in the left
a
ear.
defect in the left ear. Air conduction is significantly below normal, and so is bone conduction. However, there is a large gap between the air and bone conduction lines, meaning that there is both a sensory neural and a conductive loss. This is known as mixed hearing loss.
Next ear loss, क्योंकि यहाँ पे gap है ना, तो दोनों हो सकते हैं. हाँ.
Possible causes of this picture would be a cholesteatoma if it invades both the middle and inner ear, or trauma. Rinne's and Weber's are of limited value here and are unreliable in mixed losses. At the start of this video, we set out 5 objectives. Firstly, to describe the process of audiometry. Audiometry is done by playing pure tone sounds of different intensities and frequencies and recording which the patient can hear. Second was to demonstrate how audiograms are linked to tuning fork tests. Rinne's and Weber's are bedside tests, and although both measure air and bone conduction, audiograms alter the frequency and intensity and take more consideration of global hearing loss. They can be diagnostic in themselves. Third was to diagnose normal hearing from an audiogram. Plot points for both ears should be above the 20 decibel line. Fourth was to be able to diagnose conductive and sensory.
Okay, done. So this तो कुछ तो समझ में आया ना. ऑडियोमेट्री, प्योर टोन ऑडियोमेट्री, कुछ तो नॉलेज है अभी इसके बारे में. समथिंग. पहले थोड़ा कुछ था, अभी और थोड़ा कुछ हो गया है. सो गुड. ठीक है. ये मुझे लेक्चर प्रेपरेटर के लेक्चर में ही देखना पड़ेगा, तभी मुझे समझ में आएगा. ठीक है, ये मुझे इंटरनेट में तभी मिल नहीं रहा. I'll bookmark this. ठीक है. 45 ईयर और हाँ, ये देखते हैं पहले. तो ये है मेरा, दिस इज़ माई एयर कंडक्शन, दिस इज़ माई बोन कंडक्शन. बोन कंडक्शन ऑफ द राइट साइड. तो देयर इज़ अ गैप. एयर कंडक्शन में इतना कम है, बोन कंडक्शन ठीक ठाक है. बोन कंडक्शन इज नॉर्मल, एयर कंडक्शन इज, तो दिस इज कंडक्टिव हियरिंग लॉस. सी, यू डोंट हैव टू रीड द क्वेश्चन ऑल्सो. क्वेश्चन पढ़ा ही नहीं मैंने सिर्फ ग्राफ देखा. सो दैट इज अ कंडक्टिव लॉस. कूल. नेक्स्ट, 60-year-old पेशेंट इज बीइंग इवेल्युएटेड फॉर हियरिंग लॉस. ठीक है, 60-year-old है. 60 ईयर मतलब हमें प्रेसबाइकोसिस हो सकता है, मतलब धीरे धीरे कम होते जाना. बीइंग इवेल्युएटेड फॉर हियरिंग लॉस यूजिंग वेरियस ट्यूनिंग फॉक्स. What are the expected findings for a patient with sensory neural hearing loss? ठीक है. एक तो what are the sensory neural ना, तो रिन्ने पॉजिटिव वेबर्स अफेक्टेड. अरे यार वो 3 चीज़ें दिया है यहाँ पे. रिन्ने पॉजिटिव कहाँ पे होता था? एयर कंडक्शन इज ग्रेटर देन दी. ओह, अरे यार सोचना चाहिए था थोड़ा. अर्जेंट से कर दिया मैंने। तो ऋण पॉजिटिव, ऋण पॉजिटिव मतलब क्या होता है? ऋण पॉजिटिव मीन्स देयर इज गुड एयर कंडक्शन कंपेयर टू द बोन कंडक्शन। वेबर में क्या होता है? बेटर ईयर में सुनाई दे रहा है क्या? वेबर से सुनाई दे रहा है बेटर ईयर में। रुको 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 रुको, यहाँ पे ऋण पॉजिटिव कौन सा ईयर पे? कोई भी है, चलो कोई भी एक ईयर है, वहाँ पे मैंने ऋण किया है। यहाँ पे ऋण करने के बाद मुझे एयर कंडक्शन मुझे अच्छे से सुनाई दे रहा है, ठीक है। अगर एयर कंडक्शन मुझे अच्छे से सुनाई दे रहा है, सो देयर इज नो कंडक्टिव हियरिंग लॉस। So what are the expected finding for a patient with sensory neural hearing loss? ऋण पॉजिटिव सेंसरी न्यूरल हियरिंग लॉस में क्या दिखेगा? एक्सपेक्टेड फाइंडिंग क्या होगा? ऋण अगर पॉजिटिव है, that means there is no conductive hearing loss. It can be a normal or it can be sensory neural hearing loss, है ना। और अगर ऋण नेगेटिव है, मतलब बोन कंडक्शन इज बेटर, that means there is conductive hearing loss. तो हाँ, यहाँ पे ठीक है, ऋण पॉजिटिव हो सकता है। सो बिकॉज ऋण पॉजिटिव मीन्स योर इट कैन बी नॉर्मल और SNHL। नेक्स्ट आता है मेरा वेबर टेस्ट, जो मैंने यहाँ पे डाला है। इट इज़ लैटरलाइजिंग टू द नॉर्मल ईयर। अगर लैटरलाइजिंग टू द नॉर्मल ईयर है, दैट मीन्स जो मेरा वो बोन से जा रहा है ना, सो बोन से डायरेक्ट जाके स्टिमुलेट हो रहा है। बोन से डायरेक्ट जाके स्टिमुलेट हो रहा है, मतलब मेरा वो सही है। क्या सही है? इज ऑन द बेटर ईयर। तो ऑपोजिट साइड में रॉन्ग होगा ना कुछ, ऑपोजिट साइड में सेंसरी हियरिंग लॉस होगा। और शॉबैक से शॉर्टर, शॉबैक में क्या किया जाता है? शॉबैक में कंपेयर किया जाता है विद द एग्जामिनर, है ना। कंपेयर करने के बाद वहाँ पे उसको कम सुनाई दे रहा है। So, in a patient with sensory inducing hearing loss, SNHL, the expected findings from the tuning fork test are as follows. The ऋण test will be positive, indicating air conduction is more than bone conduction. The Weber's test lateralized to the better ear, reflecting the diminished hearing in the affected ear, which will show a shorter duration of hearing compared to the examiner, indicating SNHL. Is there a possibility कि क्वेश्चन थोड़ा और अच्छे से डिज़ाइन किया होता है? समथिंग लाइक दैट।
Hi everyone. This question is on a 60-year-old patient who's been evaluated for hearing loss with tuning fork test. They're asking you what could be the expected finding in a patient with sensory neural hearing loss. So we know that in sensory neural hearing loss, Rinne is always positive. Weber is directed towards the normal ear or the ear which is not diseased. Absolute bone conduction will be shortened and even Schwabach's test will be shortened. So the option that gives us Rinne positive is option A and option B. The option that gives me that Weber is getting lateralized towards the better ear is option B. And now we can come down or narrow down to the diagnosis of SNHL with tuning fork test with option B, showing to you even Schwabach's test is shorter. So the correct answer is option B. Thank you.
नाउ आई हैव टू, वो मुझे को रिवीजन करना पड़ेगा। वेबर्स टेस्ट एंड रिनीस टेस्ट, है ना। ट्यूनिंग फोक टेस्ट डॉक्टर नजीब का एक लेक्चर है यहाँ पे, मस्त बढ़िया सा, वो देख लेंगे।
Post-corona, when we were looking for a school for our son to start his standard 1, we came across Basilod.
Now, we are going to talk about, first of all, Weber's test. Weber's test, what you really do? Yeah, Weber's test, of course, first of all, you must have a tuning fork. And you should get it by dating. Then when you put the base of the it is a vibrating tuning fork. Right? Now, actually, what really happens when vibrations of the tuning fork are producing sound, these are passing through the bones from both sides. They're passing through the bones, and they will come to the ear and directly stimulate sounds through the bone. They'll stimulate the apparatus on both sides, and acupressure will start in both cochlear systems. Is that right? So you will hear as if you are hearing this tuning fork from, if your ears are absolutely normal, you will hear as if you are hearing this tuning fork from
both the sides.
both here, and you will hear from both sides equal. If you are having absolutely normal system, you're producing a vibrating tuning fork here, it will be heard on both sides equally. So we say normally, because sound conduction on this side and this side is same, and sensory nervous system is also healthy on both sides and working equally good, so we say sound will be equally heard on both sides, so there's no lateralization. There's no lateralization. But if there's conductive deafness on one side, let's suppose there's conductive deafness here, right? And there's no conductive deafness on this side, now one ear will hear both. Which side will hear both? Conductive deafness. Why? Because if you right now do the experiment, look, you close the tragus, close one side of the ear right now, and talk to yourself. You will find that you can do that and confirm it. Close and say anything to yourself. You see, you hear lower, that's side. Why? Because environmental noises cut off. So bone conduction from here and here is equal still. But because there's conductive deafness, so air conduction is blocked from here, so dispersions are lost, so it just lateralizes on this side. Is that right? So what really happens that if there's conductive deafness in one ear, then sound will lateralize on that side. And let's suppose if there is sensory neural deafness,
got it. हाँ ओके. सो अगर यहाँ पे मेरा कंडक्टिव लॉस है, ठीक है, ऑन दी लेट्स सपोज यहाँ पे मेरा कंडक्टिव लॉस है, मेरा लेफ्ट साइड पे, लेफ्ट ईयर पे कंडक्टिव लॉस है. सो वहाँ पे मुझे अच्छे से सुनाई देगा. क्यों? क्योंकि मेरा एक्सटर्नल नॉइस इज ब्लॉक्ड आउट. गॉट इट. सेकंड थिंग, अगर मेरे राइट साइड पे ऑपोजिट ईयर पे सेंसरी न्यूरल हियरिंग लॉस है, स्टिल दिस विल बी लैटरलाइज्ड टू दिस ईयर. ठीक है. सो अदर इफ इट इज द conductive hearing loss, then it is lateralizing to the same ear. If it is sensory neural hearing loss, then it is lateralizing to the opposite ear. ठीक है.
First we come to the normal person. First person is normal. It will lateralize to which side? None of the side. You will equally hear both sides. Then second patient comes, he has conductive deafness on the right side, so it will lateralize on the right side. Third patient comes, he has sensory neural deafness on the left side. Neural system on the left side is not working. This time it will lateralize on, still on the right side.
Same side.
It means, listen carefully, that in Weber's test, it lateralizes towards the ear with conductive deafness, or it lateralizes away from the ear with sensory neural deafness. That's the basic principle. In Weber's test, it lateralizes to the, yes, which ear? Ear with the conductive deafness, or away from the ear with sensory neural deafness. It means that if right now you do better than me, and it is lateralizing on this side, it means either right ear is having
Conductive hearing loss or left side is having SNHL.
Let us say Rennie test. Just this Rennie test. The Rennie test what happens? That you will take the
Tuning fork.
info, get it validated. First you put it on the patient's one side. And after the patient goes to a signal when he stop hearing. For example, I'm hearing it, as soon as the patient with the time becomes less, as soon as I stop hearing it, I raise my finger. It immediately moves from here and bring the prongs near my ear. If my ear is normal, or if my ears are conducting well through the ear, then air conduction should be longer than bone conduction. So it means then tuning fork, when it was vibrating here, when it stopped vibrating on the bone conduction, right, bring it here, person should hear. If person hears, it means air conduction is more than bone conduction. This is normal. This is normal, right? Normally, you people should have Weber not lateralizing to any side, and you should have the Rennie test in such a way that air conduction should be longer than bone conduction. This is normal. Now you see, if you have conductive deafness, let's suppose you block this. Number one, Weber will lateralize to this side. And number two, when you will do Rennie test, right, you will hear, keep on hearing from here. As soon as you stop hearing from the mastoid, you stop it, bring it here, will you hear? No. So what really happens? Their bone conduction was longer than.
Got it. तो यहाँ पे रेनी अगर पॉजिटिव है कोई भी केयर पे, तो आइदर इट इज़ ए नॉर्मल और इट इज़ सेंसरी न्यूरल हियरिंग लॉस. ठीक है. यहाँ पे भी सेम ऑप्शन है. यहाँ पे रेनी नेगेटिव है. रेनी नेगेटिव है मतलब दैट मीन्स देयर इज सम कंडक्टिव लॉस, लेकिन हमको यहाँ पे कंडक्टिव नहीं चाहिए बिकॉज दे आर आस्किंग दिस SNHL. यहाँ पे तो दे हैव नॉट गिवन द रेनी. ओके, सो दिस टू एंड ओके ABC एब्सोल्यूट बोन कंडक्शन टेस्ट है सेम क्या है, मतलब दोनों के दोनों कान में सेम है या फिर एग्जामिनर और इसका सेम है. एग्जामिनर और इसका सेम है. वेबर में क्या हो रहा है, यहाँ पे अफेक्टेड ईयर में जा रहा है. तो अफेक्टेड ईयर हियरिंग लॉस जो अफेक्टेड ईयर मतलब क्या बोल रहा है, क्या बोलना चाहते हैं, कंडक्टिव लॉस है या सेंसरी न्यूरल हियरिंग लॉस है, क्या है. तो वेबर्स टेस्ट इज लैटरलाइजिंग टू द अफेक्टेड ईयर. अगर अफेक्टेड ईयर में लैटरलाइज्ड है इसका मतलब देयर इज कंडक्टिव लॉस. ठीक है. और यहाँ पे बेटर ईयर नहीं, वेबर इज लैटरलाइजिंग टू द अफेक्टेड ईयर में वहाँ पे मेरा कंडक्टिव लॉस होना चाहिए या फिर ऑपोजिट साइड में SNHL होना चाहिए. वेबर बेटर ईयर में लैटरलाइज हो रहा है, इसका मतलब ऑपोजिट साइड में मेरा SNHL है. पॉजिटिव वेबर्स में बेटर SNHL है वहाँ पे, यहाँ पे पॉजिटिव है. शॉर्ट में इट इज शॉर्टर. कॉन्सेप्ट तो समझ में आ गया, बट इस क्वेश्चन के ऊपर द वे द ऑप्शंस आर अरेंज्ड एंड द वे द क्वेश्चंस आर इज formatted, I'm getting a little confused. बाकी सब तो ठीक है. मेरे को एक दोस्त से पूछना पड़ेगा इसके बारे में, if they are able to clarify. क्या था ये? कौन सा क्वेश्चन था ये? ट्यूनिंग फोक टेस्ट था ना ये सब. ट्यूनिंग फोक टेस्ट. अरे क्या खुल रहा है? Study session is done. 2 hours. I mean almost 2 hours. It's break time, huh? Hello guys, what's up? What is up? Anybody in the chat? I'm hungry now. It's almost going to be 7:30 or something. It's already 7:30. ट्यूरिंग फोक टेस्ट इज डन भाई. अभी कितने क्वेश्चंस बाकी है? अभी मैं हमने बस 12 ही करा है. 12. अभी भी तो 10 बाकी है भाई. इट्स टेकिंग लॉट ऑफ टाइम. फकिंग कॉलेज इज वेस्टिंग माई टाइम एक्चुअली. वहाँ पे जाते हैं, कुछ नहीं करते, बस टाइम पास. द फक. टुडे इज 28th. So we have like almost 1 week for the quiz and the fuck. I had to read neuro. बहुत ही इंटरेस्टिंग है भाई. I'm glad that I have taken neurosurgery electives because there is a good probability that I am getting interest in it and I might go in neuro in my PG, neurosurgery or something, whatever. Mostly surgery. It's interesting. The way brain is designed, the way it works. The professors are chill, knowledgeable. Neurosurgery. So I have to read like lot. Lot means a lot. I should pull almost 10 hours, 8 hours of study every day. We'll do it slowly. Sundays we will sit like 6 to 8 hours study session, okay? And then like 2 hours for gaming and relaxing. During holidays we have to pull around 6 to 8 hours of study. Okay, let's solve one more question and see what happens. Then we'll stop. Which of the following is the correct sequence of structures involved in the transmission of the sound from the external environment? अरे क्या क्वेश्चन है भाई. Pinna, tympanic membrane, ossicles, basilar membrane, organ of Corti and Ordiner. Tympanic membrane, pinna. Hut. Such a easy fucking question. What are you asking, huh? Okay, next. A 55-year-old patient with sensory hearing loss undergoes hearing test. ठीक है, तो इसको है SNHL. The examiner performs the absolute bone conduction test and the Schwabach's test. मुझे ये दोनों के दोनों टेस्ट में इतना थोड़ा कभी कभी कंफ्यूज हो जाता हूँ मैं. What are the expected findings of the duration of the both? ठीक है, अगर SNHL है ना तो आप दोनों के दोनों कम हो जाएगा ना. एब्सोल्यूट बोन कंडक्शन टेस्ट और शॉबक्स टेस्ट दोनों के दोनों तो कम होना चाहिए. नहीं रुको, SNHL है ना. हाँ, सेंसिटिव हियरिंग लॉस दोनों के दोनों कम हो जाना चाहिए. तो बोथ शुड बी शॉर्टर आई गेस. या सो बोथ आर शॉर्टर. ऑल राइट. नेक्स्ट क्वेश्चन. 50-year-old पेशेंट प्रेजेंट्स विथ हियरिंग लॉस. ठीक है, इन द लेफ्ट ईयर में उसको हियरिंग लॉस है. ऑन एग्जामिनेशन द वेबर्स टेस्ट इंडिकेट्स दैट वाइब्रेशन आर लैटरलाइज्ड टू द लेफ्ट ईयर. ओके, तो यहाँ पे लैटरलाइज हो रहा है, इसका मतलब यहाँ पे उसको कंडक्टिव हियरिंग लॉस है. Given the Weber's test finding, which of the following condition could be obviously? So if there is conductive hearing loss in the left ear, see, that's cool. 55-year-old patient presents with hearing difficulties during the Rene test. Bone conduction is significantly better. ठीक है, तो Rene यहाँ पे कर रहा है. Rene में bone conduction is better. That means Rene is negative. Better than the ear conduction. The Weber test lateralized to the right ear. Okay, so there is a sensory neural hearing loss on the left side. What is the most likely cause? Sensory loss on the left ear. Option A. Huh? Okay, wait. Where did I get confused? 55-year-old patient presents with hearing difficulties during the Rene test. Bone conduction is significantly better. Bone conduction is better. या बोन कंडक्शन इज बेटर मतलब वहाँ पे कंडक्टिव हियरिंग लॉस है ना. फक ब्रो, बिकॉज देर इज कंडक्टिव हियरिंग लॉस, इसलिए तो बोन कंडक्शन बेटर है. ओके, आई नीड टू गिव लिटिल मोर टाइम इन थिंकिंग rather than assuming and going to the answer directly. Okay, this was a simple easy question which I fucked up. Next. 60-year-old woman with suspected conductive hearing loss. 60 ईयर है, सस्पेक्टेड है कि कंडक्टिव हियरिंग लॉस हो सकता है. अंडरगोज द रिनीस टेस्ट. अगर कंडक्टिव हियरिंग लॉस से अगर रिनीस टेस्ट किया जाएगा, सो देयर इज बोन कंडक्शन इज बेटर देन द एयर कंडक्शन using tuning fork. The test reveals a better perception of the sound through bone conduction. Yeah, bone conduction is better than the air conduction compared to air conduction. Which tuning fork frequency is most likely to be used? Generally tuning fork test यूज किया जाता है तेरा 256 हर्ट्स, 512 एक तीनों के तीनों यूज किया जाता है. आई थिंक 512. यस, 512 क्योंकि 256 थोड़ा कम हो जाता है. 512 में आई थिंक दैट विल बी मोर प्रिसाइज रादर देन 1024 हर्ट्स. ओके, कूल. द इमेज शोज, अरे ये तो हमने कल ही पढ़ा था, सो दिस शुड बी इजी. व्हाट इज द करेक्ट सीक्वेंस? हाँ, मैं बोलता हूँ. तो पहले तो कॉक्लियर नर्व आ जाएगा, ये आ जाएगा मेरा कॉक्लियर न्यूक्लियाई. सो वेयर इज ए इज कॉक्लियर न्यूक्लियस, ए इज अरे गॉट इट, फिनिश, डन. सो ए इज कॉक्लियर न्यूक्लियर, वन ऑप्शन इज देयर. नेक्स्ट. 40-year-old मेल प्रेजेंट्स विद डिफिकल्टी लोकलाइजिंग साउंड. अच्छा, 40 ईयर को मेल है, he is feeling difficult in localizing the sounds and a reduced ability to discern speech. तो उसको speech सुनाई नहीं दे रहा है and localizing the sound. Okay, noisy environment. So there is something with the he reports no significant hearing loss. Imaging studies reveal normal cochlear and auditory nerve structure, but lesion is directly in the brainstem. Brainstem में कोई lesion है, which structure in the auditory pathway is most likely to affected. Cochlear no in the auditory pathway. Localizing sound or noise environments. पता नहीं यार. No. So superior is this? How is this like? What is this? What is this question? 40-year-old male presents with difficulty localizing sound. उसको difficult हो रहा है to localize the sound and reduced ability to discern speech. मतलब उसको स्पीच अच्छे से सुनाई नहीं दे रहा है इन द नॉइज एनवायरनमेंट. ही रिपोर्ट्स नो सिग्निफिकेंट हियरिंग लॉस। हियरिंग लॉस उसको है नहीं, तो ना कॉक्लियर पैथोलॉजी है ना उसको कंडक्टिव हियरिंग लॉस है, ठीक है। लेकिन इमेजिंग करने के बाद रिवील किया जाता है कि कॉक्लियर एंड ऑडिटरी नर्व स्ट्रक्चर्स बट लीजन डिटेक्टेड इन द ब्रेन स्टेम। यहाँ पे मुझे इसको कैच करना चाहिए था कि ब्रेन स्टेम बोला है ना, मिड ब्रेन तो नहीं है। मैंने क्या फालतू ऑडिटरी कॉर्टेक्स लिखा है भाई, यहाँ पे बोला है इसने ब्रेन स्टेम एंड ऑडिटरी कॉर्टेक्स इज इन द ब्रेन। फक ब्रो, तो देयर इज माई ब्रेन, ब्रेन के अंदर होता है मेरा ऑडिटरी कॉर्टेक्स। क्वेश्चन बोला गया है कि ब्रेन स्टेम, तो वहाँ पे तो वो सोच ना, कॉक्लियर तो छोड़ दे, वो तो मिडिल, वो तो इनियर ईयर में है, वो तो उसको तो ब्रेन से कोई रिलेटेड ही नहीं। मीडियल जेनिकुलेट बॉडी कहाँ पे है? मीडियल जेनिकुलेट बॉडी है मेरा मिड ब्रेन, हाँ मिड ब्रेन में है। सुपीरियर ऑलिवरी न्यूक्लियस मेरा ब्रेन स्टेम में, तो दैट इज द सिंपल आंसर। इट हैज नथिंग टू डू विद और ऑल द अबव क्वेश्चन जो भी वहाँ पे पूछा गया है। क्वेश्चन में सिर्फ दिया गया है ब्रेन स्टेम, तो उसके बारे में सोचना, ब्रेन स्टेम में क्या है वो सोचना। तो ऊपर क्या सोच रहा है? ऊपर ऑडिटरी कॉर्टेक्स, व्हाट द फक, व्हाई ऑडिटरी कॉर्टेक्स, व्हाई आर यू बीइंग इम्पल्सिव? यू थिंक देयर इज अ ब्रेन स्टेम लीजन, सो यू थिंक अबाउट द ब्रेन स्टेम में कौन सा न्यूक्लियस है। ब्रेन स्टेम एक है मेरा कॉक्लियर न्यूक्लियर, जो यहाँ पे ऑप्शन में दिया नहीं गया है, बिकॉज दे हैव डिजाइन द क्वेश्चन इन सच ए वे कि तुम वहाँ पे कंफ्यूज ना हो। उसने अलग अलग ऑप्शन दिया है ना, इसलिए कि कॉक्लिया एक है जो कि रिलेटेड ही नहीं है, ऑडिटरी कॉर्टेक्स जो कि ब्रेन में है, इट इज़ नथिंग टू डू विद द ब्रेन स्टेम। मीडियल जेनिकुलेट बॉडी है मेरा मिड ब्रेन में, तो बचा क्या है? सुपीरियर ऑलिवरी कॉम्प्लेक्स, और उसके साथ साथ कॉक्लियर नर्व भी था। एंड उसके ऊपर अगर मैं बोलूँ तो वहाँ पे था मीडियल लेमिनस्कस का न्यूक्लियर। ये तीनों के तीनों ब्रेन स्टेम में आ जाएगा, क्योंकि ये दोनों तो पॉन्स में है। सो दैट्स हाउ यू शुड हैव थॉट अबाउट इट। लेकिन या वॉट एवर, टाइम कम था तो इम्पल्सिव हो गया, क्या करें। So yeah, cochlear nerve, cochlear nucleus, superior olivary, lateral lemniscus, inferior colliculus जो कि मिड ब्रेन में है, देखा। हाँ, देन मीडियल जेनिकुलेट बॉडी अगेन इन द थैलेमस, वो भी मिड ब्रेन में है। एंड देन प्राइमरी ऑडिटरी कॉर्टेक्स जो कि मेरे ब्रेन में है। ठीक है, cool. Which of the following best describes the role of the phase difference between the oval window and the round window? ठीक है, it amplifies the sound, prevents the cancellation of the sound waves, allowing perilymph movement. It ensures simultaneous vibration of the oval and round window. It decreases the sound transmission efficiency, reducing the ear. हाँ, ऑप्शन है ऑप्शन डी, आई डोंट नो एनीथिंग अबाउट इट, whether it amplifies by 10 decibel or decreases sensitivity, I don't know. It ensures simultaneous vibration of the oval and round windows. Something, it makes some logic, but it prevents the cancellation of sound waves, allowing perilymph movement. I think option B is more accurate in this. What do you say? Yeah, that is the right answer. क्योंकि इसके बारे में तो I don't think so. I don't know what is it. ऑप्शन सी, ensure simultaneous vibration of the oval and round, तो इससे इसका क्या लेना देना, फेज डिफरेंस से क्या लेना देना है ना यहाँ पे। क्योंकि फेज डिफरेंस यहाँ पे इसीलिए है क्योंकि जब जब मेरा ओवल विंडो पुश हो रहा है तब तब मेरा राउंड विंडो में क्या हो रहा है, वहाँ पे फेज डिफरेंस है ना। व्हेनेवर देयर इज पुशिंग ऑफ द वन साइड ऑफ द ओवल विंडो, इसका ऑपोजिट ऐसे ऐसे पुश होगा, सो दिस इज द फेज डिफरेंस। या सो व्हाट अबाउट, यहाँ पे क्या दिया है? So it prevents the cancellation of the sound waves, allowing the perilymph movement. The phase difference between the oval window, which receives sound vibration from the steppiece, and the round window is crucial in preventing the cancellation of the sound waves. हाँ, क्योंकि अगर ये मेरा एक वेव है, यहाँ से मेरा दूसरा वेव आ रहा है, दोनों अगर सेम होंगे, कोई अगर फेज डिफरेंस नहीं होगा, so it will cancel out each other. Is it so? फेज डिफरेंस नहीं होगा मतलब अगर फेज डिफरेंस तेरा 90 डिग्री का होगा या 180 डिग्री का होगा, दैट डिपेंड्स ऑन द डिग्री ना, कि कितना फेज डिफरेंस है। ओके, व्हाटएवर, द फेज डिफरेंस बिटवीन द ओवल विंडो व्हिच रिसीव्स दिस वाइब्रेशन फ्रॉम द स्टेपीस एंड द राउंड विंडो इज क्रूशियल इन प्रिवेंटिंग द cancellation of the sound waves. The oval window receives compression while the round window experiences the rarefaction, ठीक है, phase allowing proper movement of the perilymph. हाँ, without this phase difference, sound waves reaching the window at the same time would cancel each other, जो कि obviously normal physics है. It amplifies sound waves by 10 decibel. ये क्या है? What is this? The phase difference between the oval and round window contributes to sound transmission but does not amplify. वही तो, क्यों करेगा, कहाँ से गाएगा, कहाँ से आ रहा है ये amplification? The actual contribution of the phase difference to hearing sensitivity is 4 decibel and not 10 decibel. The actual contribution of the phase difference to hearing sensitivity is about 4 decibel. अच्छा, या मतलब एम्पलीफाई तो ये नहीं करता, क्योंकि दिस इज नॉट द जॉब ऑफ दैट थिंग ओल विंडो राउंड विंडो टू एम्पलीफाई. एम्पलीफिकेशन जो भी करना होगा वो ऑसिकल्स कर लेंगे, ठीक है, इनका स्मेलियर स्टेप्स. लेकिन यहाँ पे कुछ बोल रहा है कि एक्चुअल कंट्रीब्यूशन ऑफ द फेस डिफरेंस, यहाँ पे फेस डिफरेंस कुछ सेंसिटिविटी पे ये कर रहा है, एड कर रहा है ना. दैट इज अबाउट 4 डेसिबल. सम रैंडम फैक्ट घुसा दिया है बस. It ensures simultaneous vibration of the oval window and round window. The oval and round windows does not vibrate simultaneously. हाँ, क्यों करेगा? Obviously does not. Again, that will be the same thing. In fact, they are non-simultaneous movement with movement to cancellation. Yeah. It declares sound transition. Some random fact इन्होंने घुसा दिया है, ठीक है. ये सब याद नहीं होगा, कुछ नहीं होगा. Let's move on. 2-3 more questions. 45-year-old man presents with progressive hearing loss. ठीक है, progressive hearing loss in the right ear. Audiometry reveals sensory neuron hearing loss and MRI shows no abnormalities in the cochlear nerve. तो SNH नर्व पे ऑडियोमेट्री में सुना दे रहा है और इसमें MRI में कोई कॉक्लियर नर्व पैथोलॉजी नहीं है, ठीक है. A defect in the converting mechanical sound vibration into electrical signal is suspected. Which of the following structures is most likely affected? Organ of corti. इसमें क्या सोचना है? इसमें क्या सोचना है? Because that is the only thing that is converting. अरे, what is the total amplification of the sound in the auditory system? What is the total amplification of sound in the auditory system due to impedance matching? Oh, अच्छा. Considering both the lever actions of the ossicles and the area ratio between the tympanic membrane and the oval window. तो कितना ज़्यादा होता है ये? ये न्यूमेरिकल वैल्यू तो मुझे कुछ पता नहीं है कि कितना ज़्यादा होगा. 1.3 times from the lever action, 17, 1.3, 20. Never read. एम्पलीफिकेशन तो होता है, दैट तो इज देयर, पर कितना होगा, कितना टाइम्स होगा? शुड आई टेक ए रैंडम गेस? 22, 26, 33, 21. कितना हो सकता है? लेट्स गो विद ऑप्शन बी. ओ, मल्टीपल है क्या? रॉन्ग ही था जो भी. ऑप्शन ए एंड ऑप्शन डी है. अच्छा, yeah, okay. So 1.3 times in the lever action and 17 times in the area. तो वो तो ठीक है, लीवर एक्शन में तुम्हारा 1.3 टाइम्स. अभी याद होगा ये? 2 मिनट के बाद भूल जाऊंगा मैं कहाँ पे 1.3 एंड 17. Effective vibratory area is 55 millimeters square. Foot plate of the stapes is 3.2 mm. Aerial ratio is 17:1. Lever ratio is 1.3:1. 17:1.3 is 22.1. I hope याद हो. I mean, yeah, okay, whatever. 1.3 and 17. 20 से ऊपर ही है, मतलब 25 के नीचे ही है, ऐसे तुम याद कर सकते हो कि 25 से नीचे है, 21 से ज़्यादा है, ठीक है. 21.6 है ना, तो 21 से 25 के बीच में होगा कहीं ना कहीं आंसर. अगर ऑप्शन में दिख गया तो ठीक है ना. वहाँ से हम लोग which of the following factors is most important in the impedance matching mechanism of the auditory system facilitating the transfer of sound from the air filled middle ear to the fluid filled cochlear? एयर फील्ड मिडिल जैसे वहाँ पे कैसे तुम करोगे? लीवर एक्शन ऑफ द मैलेशन स्टैपिस, एरिया रेशियो बिटवीन द दैट एंड दैट, रेजोनेंस ऑफ द वेस्कुलर अकोस्टिक. वो तो ऑप्शन ए और ऑप्शन डी गया. नॉट द आंसर्स. either it is the area ratio between the tympanic membrane and the oval window and lever action of the malleation strip. Like क्वेश्चन में क्या पूछा है कि ट्रांसफर ऑफ साउंड फ्रॉम द मिडिल ईयर टू द फ्लूइड. बोथ आर द आंसर. मोस्ट इम्पोर्टेंट क्या है? लेकिन आई थिंक लिवर एक्शन है ना. मोस्ट इम्पोर्टेंट इज एरिया रेशियो, नॉट द लिवर एक्शन. 14% मार्क रॉन्ग है. तो एरिया इज मोर इम्पोर्टेंट देन द लिवर एक्शन. ठीक है, ठीक है. याद कर लेंगे क्या है, छोटा सा तो फैक्ट है। दो चीज़ें यहाँ पे है, एक है एरिया रेशो और एक है लीवर एक्शन। तो इसमें से दोनों में से इम्पोर्टेंट ज़्यादा कौन है, प्रायोरिटी किसको देना है, एरिया, उसके बाद लीवर एक्शन। ठीक है, तो इम्पिडेंस मैचिंग देखो मैम क्या बोलती है।
Hello everyone. The question is asking us about the impedance matching mechanism. So as soon as we hear the word impedance matching mechanism, we know that this is a mechanism that is happening in the middle ear. Because the sound has to travel from an air-filled middle ear to a fluid-filled inner ear. And now when the sound travels from an air-containing medium to a fluid-containing medium, the fluid will offer resistance. To overcome the resistance, the middle ear has to make the sound stronger enough that they can penetrate the fluids of the inner ear. That mechanism, we call it as impedance matching mechanism. There are two ways how this happens. The first way is the area of the tympanic membrane to that of the oval window. We know that the area of tympanic membrane is much larger than that of the oval window, so when sound travels from a larger surface area to a smaller surface area, the sound waves get condensed and then they become more powerful to penetrate the fluids of the inner ear. That ratio we call it as aerial ratio. The second way is called as the lever ratio, where we see that the long process of malleus is about 1.3 times longer than the incus, and hence the sound waves again travel from a larger ossicle to smaller ossicle and causing a condensation of the sound waves where they become more stronger. So if we see the option B is the right answer, where they are talking to you about the ratio between the area of tympanic membrane and the oval window. Why is option C wrong? Because they are saying lever action of malleus and stapes, but that's not true. It is the lever action between the malleus and incus. So that is why
ओ
C
या
is
नो,
wrong. Acoustic reflex of middle ear muscles are protective reflexes,
हाँ
and
बाकी सब तो
resonance
छोड़
of
दो,
basilar
ठीक है।
membrane is a
लिवर एक्शन ऑफ द मैलियस एंड इनकस, नॉट द स्टेपिस। स्टेपिस तो वहाँ पे पहले आएगा मैलियस, फिर आएगा इनकस, फिर आएगा स्टेपिस। तो स्टेपिस का मैलियस से क्या लेना देना, तो इनकस से है ना, कि उन दोनों का लिवर एक्शन है। एंड उसके बाद है एरिया। ठीक है, दिस इज मोर एक्यूरेट बिकॉज दिस इज नॉट स्टेपिस हियर, देयर शुड बी व्हाट इज दिस, इनकस इन दिस पोजीशन। ऑलराइट 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 ऑलराइट। Oh my god, so we got 11 correct, 9 incorrect, and 3 missed. So we need to study more harder, I guess. Alright, so what is the time now? 19, that means 7, almost 8 o'clock. कितना बाकी है और? We are just finished 2. There is still lot 12, फिर यहाँ पे 19, फिर यहाँ पे 24, 27, 29, 29 modules and we are done with only 2. कल हम पढ़ेंगे वेस्टिबुलर, फिर हम पढ़ेंगे एक्सटर्नल ईयर, फिर मिडिल ईयर, फिर कोलेस्टियोटोमा, ESM, CSOM, otosclerosis, facial nerve, Meniere's disease, hearing rehabilitation, otalgia, nose and paranasal sinus वो पढ़ लेगी। फेरिंग्स मुझे करना पड़ेगा, फिर लैरिंग्स भी मुझे ही करना पड़ेगा। लैरिंग्स में कितने क्वेश्चन हैं? 19, 18, 17। ठीक है, हो जाएगा। यहाँ पे तुमने 1 2 हो गए, तो यहाँ पे 24, 54। Anybody in the chat? So we are done with the studying. We have just completed 2 modules in this entire week. Like if I started studying from Monday till Friday. What is today? Is Friday, Thursday? What it is today? Today is Friday. So 1 week, only 2 modules, so many concepts. See how vast it is. But the thing is, because I'm studying only 2 hours a day, that's why. If there was a possibility if I was able to study more than like 6 hours or 8 hours, I could have completed few more. mm, hmm. It's 8 o'clock, 9, 10, 10 o'clock, 9:30 से शुरू करेंगे आज गेम खेलना. सेटिस्फैक्ट्री खेलना है, सेटिस्फैक्ट्री. Anybody in the chat? Anybody? There are 2 people. Hello, what's up? What are you guys studying or doing, whatever? Can you hear my voice or what? Hello. No response. Cool. Fine, then we'll end the session here, and then we will be playing games like Satisfactory at around 9:30, 9:30 or 10 o'clock mostly. We will try to play Satisfactory, I guess, today, unless we get friends to play something else. Who is the other person watching? It's been 2 hours, huh? 2 hours. CPU usage is only 1.2%. 60 frames per second. I need to connect my pen tablet with the laptop in order to write and study along with the notes and stuff, so that I'll do on Saturday, so that I can study full day on Sunday. Sunday will be a session from morning 7 a.m. till evening 6 or 7. Whole day, entire day will be the studies with me session. So whoever is watching, if you're interested, you can sit with me, we'll study. And I have made a dedicated Discord channel for medical students. You can just join the Discord server for that medical group, and I'll also add few more other groups. Whoever is like joining the community, they will have their own space with their own related background people to talk with, chat with, and have any discussions of their own doubts and all. Like if there are people from business, or if there are people from medicine, engineering, I am not sure about it. I'll see. So yeah, you can just join the Discord server, and as we will get more and more audience, there will be more and more active discussion. You can just ask any doubt or anything if you're interested, you know, among your people. So I am hungry and I'll go and eat, and I will see you. Is there any server for business? If we get people from that background, from that field, then we will make a different server for business people too, in order to have their own space and they can talk out their own doubts and discussions, whatever it is. Currently, today morning I made a separate server for medicine people. So if they are interested to join, they can join and discuss with me and other peers. But right now, as the channel is new, the community is new, we don't have much people. Slowly, I am hoping that we will have more number of active people who will like if they have any sort of doubts and discussions, they want to do quick text, and there will be people who can resolve it or talk it out. So that is the basic idea. And I also have separate servers for gaming sessions and stuff. So yeah, according to your own interest and all, we will sort out and make more servers, channels. All right, so let's see how this thing goes. So whoever is watching, please subscribe to the channel, join the community, like the video, and yeah, here we play games, we study, we talk, interact. Okay, chalo then, I'll see you at 9:30 or 10 o'clock. If you're interested in gaming, you can play with me, or you can just watch the live gaming session. I hope we will be playing either Satisfactory or something with our friends, online Discord friends. Alright, chalo, bye.